So welcome back, everyone. Now, this is the Ocular Surface and Cornea 1 session. And I request the chairs for the session, Dr. Tulika Chauhan and Dr. Shreyas Ramamurthy, sir, to please come on the stage. And our first speaker in this session is Dr. Tulika Chauhan. She's a skilled corneal transplant and refractive surgeon at CFS Delhi with keen interest in keratoconus, limbal stem cell deficiency, corneal dystrophies, human optics, artificial iris, and many more. And you already know her since yesterday, the hands-on session that was held. So over to you, ma'am, on the topic overview of diagnostic tests in cornea and ocular surface and color coding, an interactive session.
Roll it call? Okay, fine. Take it. Good morning, all. Good to see you after long Sunday. You are motivated crowd. Because after that long Sunday, your faces still have a big smiles. That's good. So before I start, I just wanted to say that no answer is a wrong answer when you are learning. So please answer, and if it is a wrong answer, we will correct you. I might not be able to answer all your queries here, but if you ask question, then I will also read. So we are teaching each other here, so let's teach and start the drill here. So in corneal diagnostic, we have mainly slit lamp examination, corneal diagrams, imaging techniques, tear film evaluation, and laboratory assessment. Dr. Abhishek Dave has already covered slit lamp examination. I won't be able to cover everything here, but mainly whatever you are practicing in your day-to-day practice, we are going to cover few of the diagnostics tests which are very important. So corneal drawing. Before I start, I want you to answer that why we have to draw. Come on, guys. We have to talk. It's not like I'm just teaching one way around, right? So why we are drawing? Yes. I can hear medical legal like louder because yesterday I stressed upon that point a lot, I guess, right? Okay. So the standardization of documentation is very important because at your level you must be thinking clinical aspects are very important, but sooner you will be in the clinical practice and you know that how important the medical legal aspects are. Then easy follow-up, of course, comparisons. You might not follow up your patient every day, so your colleague will be following up. If you made a very good corneal drawing, then it's very easy to follow up. Teaching, like I'm doing here, and you will do it sooner, later in future. So colors. Again, the question a lot of people know, answer. How many sketch pens should be in your pocket if you're a cornea fellow? Very good. So everybody knows everything. It's just a revision, right? Okay. So let's go with the 6 sketch pens. The colors are, one answer I gave, red. Come on, guys. I need answers. And yellow. There's one more point I want to say. Yellow color can be exchanged with the orange color. Sometimes the visibility is not good. So many people use orange sketch pens also. Okay? So black color. So I give one tip to people who are there. So who will tell me black color? When you will use black color? And the tip I gave you to remember that you will never forget, never open your book? Okay. So the tissue which is dead, the tissue which is dying, and the foreign bodies, which are not an ocular structure, can be drawn with the black color. So scar, degeneration, dystrophies. I mentioned Goutet's and Voxtria, especially Goutet's are dystrophy and Voxtria degeneration, because they are very commonly you will see in your clinic. Ocular structure drawn with black colors are corneal nerves and limbus, and suture, contact lens, foreign body, tissue adhesives, IOL, everything will be drawn with a black color. So this is the limbus. There are 3 pictures. Corneal scar, if it is a dense scar, it will be black shaded area. If it is a patchy scar, you can use solid black dots. If it is a contact lens, it should be dotted circle. Blue color. The pearl is, you have to remember blue sea, water, right? So if you will forget that what to draw with blue, you will do what? That blue refers to water. So when there is a edema in the cornea, when the cornea is full of water, we can draw it with blue color. So epithelial edema, any epithelial bullae, stromal edema, descemet folds can be drawn with a blue color. Right? Clear? And I also told you that we never mention corneal edema on clinical papers. We'll always mention which layer of cornea is edematous. For example, stromal edema, microcystic epithelial edema. This way you can mention things on your paper. So like this. If you're making descemet folds, it's a sparse wavy lines. When you're making stromal edema, it's a dense blue hatchings. And then epithelial edema are always blue circles, which are not solid, they're blue rings. Just remember they're blue rings, not blue dots. Blue, yellow, and orange again. Who will tell me what you want to draw with orange color? Yeah, so the pearl was the flame. You see the flame, it has yellow and orange color. It's hot. Inflamed eyes are hot eyes. They're considered as hot eyes. So when you're drawing any infiltrates, hypopyon, ulcer, keratic precipitates, we use yellow and orange color. Ocular structure is a cataractous lens, can be drawn with the orange color. Green color. So remember, green is the color of surface, right? So anything happening on the surface or on the continuity of epithelium can be drawn with a green color. So epithelial defect, fluorescent stain discontinuity of epithelium, any kind of SPKs, Ps and PKs, filaments are always on surface, they can be drawn with the green color. So filaments are solid green lines. It can be horizontal, vertical, depending upon that how they're present, you can see in your clinic. The solid green dots are punctate epitheliopathy, and epithelial defects is green shade. Now the red, no rocket science here, because red is where the blood is, right? So you'll remember that, you will not forget. So ocular pathology like hyphema, hemorrhages, rose Bengal stains, and very importantly, blood vessels are drawn with the red color. So how you draw it? Superficial vessels, they will be start from that side of limbus to the corneal side. How you want to report it? You will, like for example in this picture, superficial vascularization 2 millimeter inside limbus, from 1 clock hour to 2 clock hour or 8 to 9 clock hour, you have to mention like that on your clinical papers. So when it is regressing, you will see that patient is responding or not. And the deeper vessel, the stromal vessels are drawn as a solid lines which start from the limbus. Ghost vessels, who will tell me what ghost vessels are? They're the empty vessels, right? Okay. Sign off? Yes, good. So these are drawn as a dotted lines. And rose Bengal stain as a solid red dots. Brown color. Pigments, it represents pigments. Any kind of pigments, just draw it with blue color, brown color. Peripheral synecdoche and iris and pupil are drawn with a brown color. You have to follow clock hour rule for the perfect corneal drawing, which we discussed. Like a lot of people were there. So this is an ulcer. When you're measuring it, how you're going to measure it according to clock hours. Superiorly, 4 clock hours extended. Inferiorly, again 4 clock hour. Temporally, 2 to 4 clock hour. And nasally, 10 to 8 clock hour. So why it is important? Why I want to measure it like a clock hours? Yeah, because patient will come to you with 8 millimeter of ulcer, and it's coming in 24 hours again. So when you make your drawing like this, you will know that patient is responding to treatment or not responding, right? So that is why the size of the ulcer is very important. How to draw? So there are 3 things which I use whenever I have to draw. First thing is vital staining, second is frontal view, and third is slit view, right? Why vital staining? Because vital staining will waste a lot of time, right? In the clinic, why just not draw and just finish your work? Why you're wasting time? Who will tell me what vital stain you use in your clinic? Most commonly, yes. What else? So basically, we use a fluorescent stain, Lisman green, and rose Bengal, right? Most commonly, we use very abundantly available fluorescent stain, right? So yes, so vital staining we are doing before any corneal drawing because we want to know the extent of the pathology. We might see the ulcer looks 5 millimeter and then a lot of infiltrates, but when we stay in the ulcer, it might be 7 millimeter and then it will help you in follow-up, right? So that is why vital stainings are important. You might miss some pathology, it's not about ulcer. There are many pathology which you cannot see in the naked eye with the torch, or maybe on slit lamp at your level, you might miss something. The moment you stain the cornea, what happens? There are a lot of hidden pathology which you can see, which stained, right? So you have to draw that because you're not only getting ulcers in your clinic, right? So vital stains are very important before you're doing your corneal drawing. Frontal view and slit view are important. So first we draw the frontal view, like draw a circle of 35 millimeter to represent the corneal limbus. Limbus will be drawn with which color? Good. Add pupil as a landmark. Color of the pupil? Very good. Then refine the opacity. You make your main pathology like scar, degeneration, infiltrate, edema, and then draw their adjoining signs, like vessels, pigments, posterior deposits, or folds. And draw quadrant by quadrant. Finish one quadrant, whatever you can see, then go to the next quadrant so that you'll not miss any clinical finding. Slit view is very important. It indicates epithelium as 2 lines, so we can draw defects, edema, microcyst, add stromal opacities and vessel at the accurate depth, and insert the posterior finding like descemet folds, corneal guttae, and pigments and capes. So this is a picture I want to show here. So can I use the, okay. So if you see that the first circle is a blue deep circle, right? Blue circle. So what does it indicate? Very good. The green circle, yes, and orange circle in between represent what? Infiltrate, right? And there are, and there are sparse blue wavy lines, DM folds. So when you see this and you draw the frontal view here, in frontal view, this orange deposits are until mid-stroma, but that you cannot see in the frontal view. That is why the slit view is very, very important because it can tell you the depth of the infiltrates here, fine? And the follow-ups are very important because in this follow-up case, everything decreased here, and infiltrate is in the anterior stroma. And this is the final follow-up of the patient where scarring is formed. This is an eye which you can see. Somebody wants to tell me that what they can see in the diffuse picture. So the corneal details are not, the corneal is so hazy that details are not visible. But when we see the slit, we can see some hypopyon there, right? So when we draw this patient, so what are the findings we can see in this patient, right? So this is a frontal view and the slit view of this patient. We can see hypopyon, hemorrhage and hypopyon, which is drawn in a slit here. And then there are pigments and capes, there are old scarring, and the scarring depth is anterior stroma. There is stromal edema, there's a microcystic edema, and there is a descemet folds. So all drawn, and you can relate it with the clinical picture also. So these are the drawings. Because I have not covered everything, these are the pictures which you can put in your clinic. Slit view and frontal view, and these are some uncommon changes which you can see, so that whenever you want to draw something, you can refer these pictures before drawing. And if you draw every day in your clinic, you will not forget which color to use when, okay? So right. So this is about the corneal drawing, very basic, which you can use in day-to-day practice, okay? And now the imaging technique which I want to cover here. There are many imaging techniques which we are using, but we are just going to cover specular here because that is available in all the medical colleges you're doing in your day-to-day practice. So the light incident on the epithelium, what happened in specular refraction? The light is incident on epithelial surface, it transmitted, passes through the cornea. 3 things will happen whenever the light passes through the cornea. Some part will be absorbed, some part will be transmitted through cornea, and some part will be reflected back because stroma has cells, keratocytes and nerve fibers. The light which is transmitted through cornea will go to the posterior cornea, and most of the light will go to the aqueous, but the little light, like 0.2% light, will reflect it back because of the cellular structure and the change in the refractive index. And that light will, if it is reflected specularly, then this image, from where it is reflected back, form the mirror image on the screen of the specular microscopy. So you will just see the mirror image of this area on your screen. So the clinical application, we all know that we do the assessment of donor cornea, donor corneal edema, degeneration dystrophies, endotheliopathies, eye injuries before cataract surgery. The most common thing is to do it before cataract surgery to understand the prognosis post-surgery if patient has a sick cornea. This is a video by which I want to show you that how to do specular microscopy, what we're doing. So we do specular, we take multiple images, then we select the images which are good contrast and the good images, and we can discard other images. This is a way we are doing the automatic this thing. So automatically they analyze. You can increase the range when you're doing the automatic calculations, and then it will analyze the bigger area. Whatever area you want to analyze, you can increase the range. And there's another method which we call manual method, in which you can always mark the center of the lens, and we count the cells, and then the machine will replicate the data according to the endothelial area. So when the automatic method is available, why we are using the manual method? So manual method is very important when we are dealing with such cases. So there is a specular microscopy picture which is there on the screen, but if you see this patient, the the cell density is 2872, which looks like very normal, right? But if you see this endothelium doesn't look normal to me. I don't know whether you think that good cell density is there, so this endothelium must be good. So no, because they have calculated it with the automatic method. So wherever the cells are, the machine calculated those area. It has not calculated the area where the cells are not there. So it can be misguided. So when we do the quantitative analysis, it can be misleading. So what happens here is, we do the manual method where the gouttes are there, where the bad surface are there, right? So for that, we need a quantitative methods are these. So we count number of cell, we do the cell density, we count the central corneal thickness, and we measure the average cell area and standard deviation from the normal, right? So, but these things will give you the quantitative analysis. Quantitative analysis sometimes will be misleading if you don't have a picture. So for that, we have a qualitative analysis. Coefficient of variation is very important factor. The only thing is, it looks a very complex term, but if you see, it is not. Coefficient of variation means there's a variation in the size. So how much variation can happen before the functionality of cell is lost, right? So how much we can, your hexagonal cell will work until what level? So coefficient of variation should not be more than 33. In text, I already told so many people that in literature it says 0.25 to 0.33, but it should not be more than 33. This way, if the cell are bigger than this, then they might lose their function. So if you want the cell should work properly, then they should not be the variation should not be bigger than this. So it's a measure of polymegathism. These are the pictures which show the polymegatic cells. Another qualitative analysis is hexagonality. It is in some machine, it is written at 6A, percentage of hexagonal cells. It is a number of hexagonal cells which are counted, and it should be more than 50%. Why I'm saying more than 50%? Why I'm not saying 100%? Because the moment you're born, your aging starts, and the hexagonal cell will start losing their shape. You will have some amount of pleomorphism. So this is a measurement of pleomorphism, okay? So first we see the qualitative analysis, then we see the quantitative analysis, and the picture should always be compared. So again, I want a volunteer who will read this specular for me and tell me what's the diagnosis. So anybody? So CCT is 556. It look normal to you all? And cell density is 2661. Coefficient of variation 31, which is less than 33. And hexagonality is 64%, which is more than 50%. So that means the diagnosis is normal endothelium, yes. Now, this is a patient, one patient has morning blurring of vision, both eyes, which improves by afternoon, and another patient is slowly progressive vision, like this 2 eyes, and then it is not improving. So with the specular, what would be the diagnosis? What would be your differential diagnosis, or what diagnosis you'll make in this patient? Give me the answer. Wrong answer is not a problem. No answer is a problem. Okay, so this is a Fuchs patient, and the second picture is a very advanced Fuchs, okay? In first picture, there are gouttes, but if you see, the cells around gouttes are also abnormal. You will not have a normal cells around gouttes, right? And it become abnormal. The cells which are nearest to gute will be most abnormal cells, and then you can see this change in the shape and size of the lenses, okay? In this, you cannot even identify any hexagonal cell. So if you see, in this patient, the hexagonality is at least 26% to 32%, but in this patient, the hexagonality is almost 0. We cannot identify the hexagonality in this patient, right? So it is a case of Fuchs, okay? There's again a young man, 24-year-old, redness, photophobia, this kind of specular. Right eye looks pretty normal, left eye looks lot of black holes in this. So what you want to tell me? Is it a Fuchs because the gouttes are there? Who will tell me? Can I take names if I know the names? Like Meenakshi, would you like to help me with this? Yes, cell density is absolutely normal. So that's why I said that quantitative measures should be seen last. You have to see qualitative indices first, pictures, and then quantitative indices, right? So cell density is good. 2406 is a good cell density, right? Then the CV is 32 in this, which is less than 33%, of course. And here CV is 51. Hexagonality is 27%, here is 38, right? So tell me why it is not Fuchs. First thing, if you see the picture, the cells around these black holes are normal. You don't have abnormal cells around that. So it is not a goutte, right? Secondly, patient's age. Patient is 24-year young man. Thirdly, redness and photophobia. Which Fuchs has acute symptoms of redness and photophobia? No, right? Thirdly, unilateral picture. Fuchs can be asymmetrically bilateral, but if you see there are severe changes in the left eye, but the right eye, no changes, right? So the diagnosis would be, yeah, patient has keratouveitis. In the next picture, if you see, this is a presentation. Post-treatment, the patient's left eye just indices are normal, okay? So for your viva, you should be able to differentiate between gouttes and pseudogouttes. Okay. This picture, the person who were not in yesterday's session can tell me what's happening here. Okay. Okay. So if you see the picture right side, the hexagonal cells are there, and hyperlucent cells and surrounded by the dark boundaries. But in the another picture, the center is dark, and the boundaries are hyper, right? So क्या हुआ है यहाँ पे? What is happening here? There's a reversal, right? So it is called dark light reversal. It's a picture of eye syndrome, loss of cellular definition, hexagonality is not there. There's a dark light reversal. It's an eye syndrome, okay? It can be a spot diagnosis. You can get these questions in quiz. Again, last but not least, this patient, what you can see in this? So the dark area, just focus on the dark area. The cells below the dark area and above the dark areas are normal. They are hexagonal, they are nice cells. So this is one sign which I wanted to show you because so many times it comes in quiz and sometimes people will just show you the printout and ask you the answer. So it's a donut sign which we see in posterior polymorphous corneal dystrophy. It is very slowly progressive and sometimes it's just stagnant. So you will have a good endothelial function and patient will not have any signs of endotheliopathy in such situations, okay? It's a donut sign because the center cells are normal and the cells outside the dark circle will be normal and that's why it's called donut sign, okay? So again, another thing I want to cover very fast is microbiology, a little bit, because I think I cannot cover everything in 45 minutes, but I will show you some video how to take a pen you can use so that a person who is going to stain your specimen will know that where the specimen is. And then another one is for the KOH stain, and you can always write KOH on that so that there's no confusion that what stain to be done. And then you have to take specimen from the base of the ulcer also, apart from advancing, for the culture media, and use different separate blades for plating different media. Okay, these are culture media. You'll get a hands out so that it will be notes for you. And these are the few growths which I want to just show you here because this topic will be covered in the different session again. So the left is Staphylococcus, right is Streptococcus on the blood agar. This is a Thayer Martin media. It's a Neisseria growth on this, and Mycobacterium algae media, and there's a Candida on the sabrods. Okay, these two slides for the Pseudomonas and the Streptococcus pneumoniae. So the gram staining is very important that you can do, like a lot of people are do in their own microbiology setup, so it is very important stain. So the sensitivity is 55 to 79%. It distinguishes bacteria and fungi. If it is gram positive, it is purplish blue. It is gram negative, it is pink. So I would like to, these slides you can get because I think I'll be delaying the next presentation. I'll show you the pictures and then these notes you can get from me, okay? So gram-positive rods will look purple rods. And these are the 4 pictures, gram-positive rod, gram-negative rod, gram-positive cocci, and the gram-negative cocci. In your residency exam, you should know what are the most common gram-positive rods and cocci, gram-negative rods and cocci, which are responsible for the corneal pathology. So these questions can be asked. So just give me the answer for this slide, what you can see in this. One person. Okay, gentlemen, second, third row. Tell me, sir. Yeah, so this is a mixed gram-positive cocci and the gram-negative bacilli. So you might get such kind of picture, okay? Okay, so acid-fast staining, again, we use Zeal-Lensel stain, and it is for Mycobacterium, actinomyces, and Nocardia. Mycobacterium are acid-fast, Nocardia is variably stained, and actinomyces is not acid-fast. So this picture I will not explain here, but if you see this diagram, this is Mycobacterium, which is stained pink after acid-fast. So this kind of stain you can see. This is a picture not from the eye, just wanted to show you how pseudohyphae looks like on KOH. So this is the budding cells are there, and the pseudohyphae are there. Okay, tear film. How much time I have? 5 minutes, okay. So tear film evaluation, these are the battery of tests we do in our clinic. Not everything we are doing, but these are the tests available to see your ocular surface. And the most important is Schirmer, which you can do in your clinic. So I can tell you because everybody must be doing Schirmer in their clinic, right? So it assesses the lacrimal gland function. We use Wortman filter paper 41, and the dimension is 5 into 35 millimeter. What we do, 5 millimeter tab is folded at one end, and bent end is placed at the junction of the lateral 1/3 and middle 2/3 of the lower conjunctival sac. But there's a reason why we put it here. Who will tell me this? Who will tell me? Yes, sir. Lady, first row. Because the tear pooling is more here in this area, right? So we do that here, and then we will interpret. It is insufficient tear production if it is less than 10. 10 to 15, possible shortage of tears. And if it is more than 15, we sell it normal tear production. Schirmer tests are 3 types. Schirmer 1, no topical anesthesia. It measures the basal and reflex. Jones test is with topical anesthesia. And third one is not very common. It's a reflex secretion. So how to read Schirmer? If the Schirmer 1 is decreased, the lacrimal gland disease possibility, reduce or absent ocular surface sensitivity, and the disruption of afferent nerve from ocular surface to midbrain. Schirmer 2, if it is more than 1, then ocular surface disease, it's a non-Sjogren syndrome. And if the Schirmer 1 and 2 both decrease, then we have more diagnosis like lacrimal gland disease or Sjogren syndrome can be the option. So corneal staining, I would like to cover only fluorescein here. So it does not stain normal epithelium, devitalized cell. Any break in the epithelium, penetration of fluorescein in adjoining Bowman's and stromal area, dye makes contact with alkaline interstitial fluid, and fluid turns bright green. So because you're using most commonly this, so how to interpret and how to report fluorescent? So it can be reported as stain positive. Stain positive is stain epithelial defect, bright green. It shows the breach of epithelial barriers. So if you see this clinical picture and with the blue filter, you can see the defect is there, okay? Now, the second reporting is the dye is pooling, the pooling of dye. It happens when there's an accumulation of dye because indentation and thinning, right? So when can it pool? Very common you will see. Dellen, right? The picture is Dellen picture, and you can see the pooling of dye. Negative staining. Negative staining doesn't mean no staining. You have to report negative staining because fluorescent dye flows through the ridges like irregularity in corneal surface, and it seems darker than the surrounding areas in the cobalt blue light. It is a very severe EBMD patient, and when you stain the patient, this is the negative staining you can see. So it doesn't mean that the cornea is not taking stain. Cornea is into negative staining. Why it is important? It is very important because nowadays we are doing a lot of premium lenses and a lot of surgeries. If your surface is not good, can you give a good vision to the patient? You cannot. Your patient will be very unhappy. And a lot of people miss this. They don't see this. It is there. And after that, patients are they're complaining. So if your negative staining is too much in the center, more than 20%, your vision will be compromised. Right? So you should always stain your patient if you have like EBMD or any kind of corneal pathologies, and that will show you that that will help you to counsel the patient. So what diagnosis for the first picture? This picture. Dendritic. This is geographical ulcer, and this is a combination of both. So this question, why I put here, because I have no time, I cannot ask a lot of questions. You should be able to know how to differentiate between pseudodendrite and dendrite. So this is like a herpes simplex picture, and there's a geographical ulcer and dendrite picture, but you should know that. So in rose Bengal, it stained healthy and dead tissue both. So very importantly, this is herpes simplex again with the rose Bengal. And this, who will tell me? The first picture is non-stained, the another picture is stained, punctate staining with the rose Bengal. Perfect. Because these things you will see in your day-to-day practice, you should know. So for OSSN, you can use rose Bengal staining. Lisman green, again, preferably stain membrane damage or devitalized cells. It doesn't stain healthy ocular surface and proliferating cells and has a minimal effect on cell viability. It's seen best with the red barrier filter. Lisman green is not abundantly available. But why we prefer that? Because rose Bengal can sting very badly sometimes. So that is why Lisman green is very, very comfortable to the patient. So if you see this patient, a 60-year-old male complaining severe discomfort, foreign body sensation, chronic in nature. So when we saw this patient clinically, we can see this. Can anybody, I know that only this picture will not help you with the diagnosis, but when I stain it with the Lisman green, this area is only stained. So is it a logical complaint? Like, is he just complaining or there is something happening in his eye? Yes, there's something happening, right? So superior limbic keratoconjunctivitis looks like the patients are very uncomfortable in the situation and you have to treat this patient, okay? This picture, conjunctival staining with the Lisman green. Conjunctiva, usually it stains or it doesn't stain. You have to read all this. The basic question will be asked in Viva, right? So this is a picture which is showing keratoconjunctivitis sicca. It is staining conjunctiva in all the 4 quadrants. That's how you classify your dry eye. And this is a summary. I would like to, you can get a hands out from me. There are a few things I have added, but I think I have no time. I'll give you the printouts of my presentation. Thank you very much for listening to me. I hope I have not extended my time. No, thank you.
Thank you so much, ma'am, and that was like the perfect timing as well. And the topic that ma'am has covered, you guys come across very often, and I'm sure that all of you must be feeling, oh, we've all been doing it wrong. So I hope you take home the message of how to do it right. And so our next topic will be corneal topography, an interactive session by Dr. Shreyas Ramamurthy, who is a renowned cornea, cataract and refractive surgeon and a director, and senior consultant at Eye Foundation Group of Eye Hospitals, Coimbatore. Over to you, sir. So just one more announcement that please don't worry about taking down notes. Okay, so all of these sessions will be converted to handouts and they will be handed over to you. Don't worry about it. Okay, don't need to take pictures. Be comfortable. Try to listen and learn. Okay, so that you don't, if you're wasting your time writing, you might not be able to listen. So just enjoy it. Okay.
Good. I think there's a lot of excitement behind closing your books and not taking down notes. But so, good morning, everyone. And at the outset, I would like to thank Dr. Honavar sir for having me over. And it's a pleasure to be a part of this program. I think it is almost the 10th year running that you're having this program, sir. And I think almost generations of PGs now are benefiting from this. And so today I'm going to be talking to you all about corneal topography over the next half an hour. 15 years back, when I was a postgraduate, corneal topography was still something which was not a very, very important exam topic. But in this last decade and a half, it has really revolutionized the way we are looking at not just for refractive surgery, but our overall cornea practice, anterior segment practice, cataract surgeries. In all these aspects, topography is now a very invaluable tool, and it is a part of every practice that you are present in today. So I think it's important that you have a very good idea about corneal topography and understand it clearly. And once you start understanding corneal topography, you'll really enjoy it and enjoy using the device and the tool itself. So let me try and go over some of the basics of corneal topography. And this is supposed to be an interactive session. I'm not really sure how I'm going to interact with all of you. So please feel free to stop me at any time, now that you're not having to take notes. So just raise your hands, and I would be more than happy to explain any concept that you think you've not understood clearly during the course of this talk. So essentially, what is topography? Topography is not a device or is not a tool which is only specific to ophthalmology. In fact, it came from the study of the surface of the earth, essentially looking at the features of the earth. So this is a map that you must be very, very familiar with. You can look at the Indian subcontinent. You have the plains, which are in green. You have the Deccan Plateau, which is in yellow. You have the Himalayas, which are much higher, which are in red. So just a simple depiction of the fact that colors being used as a tool to show different elevations, different surfaces is something which is an age-old practice, and that is what we are essentially applying in corneal topography. Earlier, corneal topography was just restricted to the anterior surface, where essentially we were looking at essentially a more modified version of the curvature, where you can see the red areas are essentially steeper parts of the cornea, the yellow and green are slightly flatter, and as you go to further cold colors like blue, these are very flat areas in the cornea. So just a very simple depiction. Now topography has gone way beyond this, and you actually look at different surfaces, your anterior cornea, your posterior cornea, your elevations, as well as pachymetry, and that is what modern day corneal topography is about. Currently, the topographers which we use, which are elevation based, are one, the slit scan, which is the OBSCAN 2. You also have a more advanced version of the OBSCAN 3, which I won't be discussing in this talk, but that's also available now. You have the Scheimpflug devices like the Pentacam, Sirius, and Galilee, which are all extremely useful and are currently the standard of care. Fast catching up and possibly likely to make Scheimpflug obsolete over the next decade or so. So when possibly y'all are in this stage and giving this talk 10 years, 15 years later, even Scheimpflug would be obsolete, and you'd be only looking at OCT-based scans and OCT-based topographers. And you have Visante, MS39, Antirion, quite a couple of other devices as well, which are really changing the way we look at the cornea itself. So for today's talk, I will restrict myself to the two most commonly available devices across the country. One, which is the OBSCAN. Although OBSCAN is slowly receding into the background, it is still something which I think is an important part of postgraduate examinations. And then, of course, the Pentacam, which is currently the most widely prevalent and widely available Scheimpflug device. So where are topography really useful? So first and foremost, I think topography is in ruling in or ruling out a patient, whether they are applicable for refractive surgery, following up patients with any ectatic disease, keratoconus, PMD, post-LASIK ectasia, looking at signs of early progression. This is extremely useful device, and early diagnosis, of course, is most important, and that is essentially what we are doing even in refractive surgery. We are trying to separate out the form-first forms of keratoconus with the normal patient. Identifying the normal patient is essentially what we are using topography for. Post-transplants, post-PK, post-DALK, for suture removals, this is an extremely invaluable device. You can also look at pachymetry as a tool for monitoring, although not as commonly used after the advent of ASOCT, but still it's one of the applications. For contact lens fitting, a good topographer is a very invaluable device. And also looking at certain biometric measurements. Now, a lot of the topographers nowadays come with other biometric measurements, looking at the anterior chamber depth, the lens thickness, all of which are very, very important for various surgeries. For anterior chamber depth is necessary for phakic IOL implantation, for lens thickness, effective lens positions are extremely important part of all biometry calculations nowadays. So without further ado, I'll take you all through a couple of these devices and go into a little more detail about the maps. So the OBSCAN 2 essentially has a slit scanning beam, and it also has a slightly more advanced Placido disc system, which was the original topographer. So it captures a Placido device, and then it has a slit scanning going from one direction to the other and then in the reverse direction. So essentially it takes 20 scans from two sides, so you get 40 slits at an angle of 45 degrees, and these slits are what are giving you the reference data points which are used for measurements. Anything between these slits are essentially extrapolated. So the central 5 mm, because it overlaps, gets imaged twice, so you have more data points in the central 5 mm, and therefore a greater reliability of the central data as compared to the peripheral data. Most importantly, you have the data from the curvature, and you have pachymetry data, that is the corneal thickness, and then you have elevation. So in curvature, what we are looking at is whether the cornea is the keratometry, essentially, whether it is steep, flat, whether there is astigmatism, whether one axis is steeper than the other. The other important thing that you are wanting to see in a curvature map is the symmetry of the map. Now, this is a perfectly symmetric cornea. I will go on to show examples of more asymmetric cornea where you have a inferior-superior asymmetry. So this is the most important part of the corneal curvature map. Additionally, you should also have an idea about the color scale and the way the color scale is shifting. So whether the colors are shifting in 0.5 diopter steps or 1 diopter steps or 2 diopter steps, all of these can be adjusted. The reason this is important is because when you compare one scan with the other, by just looking at the color, it may, the same patient may look completely different when you look at two scans. But that might only be because of how the scale has been set. So what actually looks completely green may have green, yellow, and a little bit of red in another scan if your step size or step heights are a little closer together. So the red color will come sooner. So the range is also important before you interpret the scan. The most important aspect of topography or tomography is the elevation data. And I think if I don't I'm not able to explain anything else, but I leave you behind with a good understanding of elevation, I think the whole goal would be achieved. Essentially, what we are doing with elevation is trying to create a reference surface. The reference surface, how best it fits to the cornea, based on which the points which are higher than the reference surface are positive or shown in positive numbers. The points which are lower than the reference surface are shown in negative numbers, basically higher or lower. Why do we need a reference surface? Just like I showed you in that particular map of the India map, you have a Mount Everest or the Himalayas there, then you have the plains, then you have the Deccan Plateau, all of which were shown in small differences in colors. Now, when we are looking at the cornea, we are trying to detect very focal elevations, that is focal protrusions, which are useful in detecting early forms of keratoconus. So these focal protrusions can be detected only when we have a reference surface which fits nicely to that particular cornea and shows those highlighted areas of protrusion above that best fit surface. Okay? So again, if let's say our cornea is normally prolate, that is, it is steeper in the center and flatter as we go towards the periphery. So all these points, the central to peripheral data points are taken, and a best fit sphere, most commonly we use a best fit sphere, that is the sphere which best conforms to that particular cornea, and the points which are higher than the best fit sphere are shown in red elevations, the points which are lower than the best fit sphere are shown in colder colors or blue colors. Generally, because the cornea is prolate, you would have the center which is steepest and the periphery which becomes flatter and flatter as compared to the best fit surface. I'll explain a little bit more about BFS when we go into pentacam because that is where a lot more variability is possible. In pachymetry, again, it's a very easy map to read. You have the central pachymetry. This becomes important when you're looking at refractive surgery, what is the thickness of the patient's cornea, whether they are eligible for refractive surgery, whether you can correct the kind of power that the patient has and leave behind a sufficient residual bed. All these things are important with the pachymetry map. You also want to look at the apex, that is the central part of the cornea, with the thinnest point in the cornea, and how much is the thinnest point different from the apex. If there is a significant difference, this is again a small red flag sign. This is usually the quadrant map that is selected, where you have the anterior and posterior elevations, and you have the curvature map or the keratometric map as well as the pachymetry map. And in the center, you have these various indices which are essential for detecting any amount of irregularity. So, like I said, this gives you in the 3 mm zone and the 5 mm zone, the amount of irregularity which might be present. And this is essential because higher the amount of irregularity or the variability within that central zone, these are red flag signs for detecting form thrust keratoconus. So again, we look at the color scale. It's important to have a good image quality, and then you go ahead reading the map. So again, I will go a little quicker with OBSCAN and spend a little bit more time on the pentacam. So curvature, asymmetric bow tie like I mentioned, or a significant skew deviation, these are red flag signs on the curvature map. On the irregularity on the 3 and 5 mm zone, on the 3 mm zone, a value of greater than 1.5 or greater than 5 mm, in the 5 mm zone greater than 2.5 are considered red flag signs. Again, let me tell you, right through this talk in OBSCAN and pentacam, there are no absolute values. These are just guidelines as red flag values. Any single value in isolation cannot be considered as a diagnosis itself, but in overall putting it into the picture where you have some IS asymmetry, you have some thinning in the cornea, pachymetry which is reduced, along with that you have a 3 mm and 5 mm zone irregularity, then all this put together is what comes to what we possibly call as a subclinical or a form thrust keratoconus. Again, an astigmatism variance between the two eyes is something very, very important, because usually because of enantiomorphism, you have similar kind of astigmatism in both eyes, and any significant difference is a red flag sign. And also you want to look at keratoconus as a disease entity. We often say that it starts in the posterior cornea. It's not completely true. It's not that it starts only in the posterior cornea. It's just that when it starts in the anterior cornea, we diagnose it early. We diagnose it easily. When it starts in the posterior cornea, we were earlier missing it out. And thanks to these devices, we are able to catch them early. So any focal protrusions in the posterior cornea is something which we are very, very concerned about. And that is where the ratio of the best fit surface of the anterior and posterior cornea comes into play. So anything more than 1.2 is considered a red flag sign. Again, elevation point in the best fit sphere itself, in OBSCAN, the values which I am portraying here are considered important. And again, these values will differ from device to device. That's why I am not getting into the specific values itself, but it is important for you to have a pattern recognition rather than reading into the actual values. Again, like I said, any significant difference in the pachymetry from superior to inferior or from central to the thinnest point of greater than 20 microns is again an additional red flag sign. Overall pachymetry being thinner also warrants a second look, and you want to know whether this patient is having any other problem. Quickly going on to pentacam. Now the pentacam is a true Scheimpflug device. Now the Scheimpflug device is essentially, you can either have a single rotating camera or a dual Scheimpflug device like in the Galilee. But essentially what it does is it gives you a lot of elevation data points, and it also gives you a true three-dimensional construct. by using three different planes which are converging on every single point. So all these elevation points that you get are true elevation points. There is a significant amount of extrapolation which happens in the earlier devices like the slit scan devices, where these were not true reference surfaces, but in the Scheimpflug you have the true reference surface. It actually directly images the posterior corneal surface as well. So this is the most common quadrant map that you will see when anyone is using the Pentacam, where you have the basic demographic data. You have the curvatural data of the front surface of the cornea, K1, K2, your astigmatism. You also have a quality score, which is usually what you want is to be in OK. But if you see yellow or red, that means this has to be taken with a pinch of salt. You have to look into the fact whether this scan itself is useful and whether you need to repeat it again. Again, in very irregular corneas, it may be difficult to get a quality score which is always in white, but essentially you need a repeatable scan. You also have something called the Q value, which is the extent of asphericity of the cornea, and that is also an important measure. There are different refractive devices, surgeries today, which can reduce the Q value of the cornea, reduce the amount of asphericity, improving the quality of vision. You also have the pachymetry data, which looks at the central apex and the thinnest point, and also gives you the Kmax, which is again very, very important, because following up the Kmax is one of the single most important criteria for detecting progression in keratoconus. And then you have the biometry values, and especially the anterior chamber depth. Generally, anything about 2.8 is something that is also in the anterior chamber depth. It's important to see, I don't know if you're able to see the letters INT here, internal, which means it's measuring from endothelium to the anterior capsule. Rather than external. You can also have external, which measures from the epithelium to the anterior capsule. When it measures from the epithelium, the CCT has to be subtracted for you to get the anterior chamber depth value. Anterior chamber depth value from internal of about 2.8 or above is considered safe for phakic IOL. Anything less than that is something you need to have a relook again. Again, none of these are absolute values, these are just guidelines. Curvature map, like I mentioned to you, an IS asymmetry, as you can see here, an inferior steepening. This is suggestive of a patient with ectasia or keratoconus, whereas you need to isolate them from steep corneas. So in steep corneas, you may have a value of 49 or 50, but if the cornea is perfectly symmetric, that means it's just high astigmatism and it does not indicate ectasia itself. So any localized steepness, localized asymmetry is what we are looking at. Pachymetry, again, just a uniformly thin cornea is not a red flag sign, but a cornea where from the central point to the thinnest point, the variation is almost 30 microns, as in this particular condition, is a red flag sign. Again, very, very important for you to know these basics, where what color bar are you using. The color code depiction, these warm colors, cold colors, which I'm talking about, are also useful only in the Ambrosio 2 or the Bellin intuitive color scales, whereas if you use some of the American style or the Holiday, they are actually reversed. So when you see a scan, it looks absolutely normal, but it doesn't look like the typical red and cold colors that warm and cold colors that you're used to. That's because the color scale might be something different. Also looking at your elevation data, your curvature data, what is the step height in which it is changing is also very important when you compare two particular maps. So look at the scale of reference before you make any diagnosis. An additional thing is looking at the corneal coverage, where normally what we take is a 9 mm scan, but you can have the ability to image up to 12 mm as well. And when you go further out into the periphery, it gives you more data points from the periphery, but you must also understand the peripheral data is not as accurate as the central data, so you have more extrapolations when it goes into the periphery. So as a standard, we measure the central 8 to 9 mm of the cornea, because it is the central cornea that we are most interested in. But in certain conditions, like the pellucid, where you are wanting to have a greater amount of data from the periphery, then these peripheral data points are useful, and you can even go into the individual Scheimpflug images and actually measure these pachymetry in those individual scans, because it is the sum total of the Scheimpflug devices, the Scheimpflug images, which is given to you in your color representation in the quad map. So you can actually go and look at the individual Scheimpflug scans and look at it. The additional, this one particular scan is called the densitometry scan. Not very useful, but it also gives you an approximate value of the optical clarity of the scan. So if you have a subtle haze, you can use a densitometry to look at the, to get an objective value of the kind of haze that the patient is having. Post PRK, when the patient has a little bit of haze which resolves over a period of time, you can follow up the patient with these densitometry values to have an objective measure of whether the haze is reducing. The reason why I was talking about peripheral data is just a patient with an advanced PMD where the central corneal thickness is nearly normal. And when you just image the central cornea, it looks like a asymmetric bow tie and a high amount of against the rule astigmatism, but it is the peripheral cornea which is actually exceedingly thin, and this patient actually had a spontaneous rupture. Pachymetry itself, there can be some limitations because this is an optically clear cornea. Optically clear cornea only will give you the accurate pachymetry in these devices. Any opacities, haze, the pachymetry values become very iffy. So this is just an example of a patient who this was pre-cross-linking. After cross-linking, this patient was actually referred saying that the patient has undergone a significant decrease in pachymetry from what was 433 preoperatively to now 350. So this is progression in keratoconus. The pachymetry is reduced. Does the patient require repeat cross-linking? But if you look at the other maps, that's why I said just a single value in isolation is not useful. Look at the curvature of the cornea. It's much steeper here. It's much flatter here. The reason is that the patient has a significant amount of haze induced by the cross-linking itself. And this haze, because the cornea is now not optically clear, the way the pachymetry is measured is from the anterior reference point on the anterior surface of the cornea to the point where it gets the change in reflection. So normally the change in reflection happens at the posterior cornea, but when you have an opacity, it measures an altered surface, and it is from that anterior to that posterior point that it measures the pachymetry and therefore can give you a erroneously low value. Quickly looking at the elevation data, one very important point which I would like to highlight again with the elevation data is what is your diameter of the elevation data, especially when you are comparing scans. Normally, we have an elevation surface. We have something called best fit sphere, which is what we commonly use, but you also have something called a best fit toric ellipsoid. A toric ellipsoid is something which covers, especially in an astigmatic cornea, in a steep cornea, it looks at the corneal toricity as well. But the reason why BFTE or best fit toric ellipsoid is not caught on as much as the best fit sphere is, it hides small protrusions in the cornea, which is what we are essentially looking for in a best fit sphere. But it will be useful in differentiating between a high astigmatic cornea versus a cornea which has a early keratoconus. You also have the setting where you can choose the size of the reference surface, whether you want an 8 mm, normally in manual mode 8 mm is what we use as default, but you could use a smaller zone or a higher zone. Let me show you the difference of varying the diameter of measurement. If you're using a smaller diameter, that means you're taking more central data, lesser peripheral data. So your best fit sphere will actually be a little steeper because the central cornea is steeper. If you take a larger best fit sphere reference, you're taking more peripheral data. So the reference sphere will actually be a little flatter. So based on this, your elevation data points will change. Now normally in a pentacam, anything more than 18 in the posterior cornea, we consider a red flag sign. Now here it is just borderline, you're not sure. But look at the diameter, it's a 7 mm best fit sphere. If you take a 9 mm best fit sphere, it is highlighting it and showing it as 39. Now, this is the same patient, same cornea, same curvature, but because of choosing different reference spheres, it gives you different values. So, it's important that you look at these and don't look at just the value in isolation, but look at the reference spheres and before you make a comparison. This is a toric ellipsoid. Now, for the same patient who is showing a significant elevation on the posterior surface, because the toric ellipsoid conforms better to the surface, there are hardly any elevation data points in the posterior surface. So BFT not useful for differentiating normal versus FFKC, but differentiating a high astigmatism versus a KC, a BFT can be useful. So I think because of paucity of time, I'll just run through this. Now this is a patient, again, you have to differentiate between person with a thin cornea versus a abnormal cornea. So this is just an example of a patient with a lower pachymetry but otherwise a symmetric cornea. I'll leave you all with this, just one final this thing about enhanced ectasia screening, which is again very, very important part of the pentacam imaging. Now, what this does is the enhanced ectasia is trying to again highlight focal areas of protrusion in the central cornea, even more than what the regular elevation data is giving us. How does it do? Now, the best fit sphere takes all the data points from the center to the periphery till the 8 mm zone that you're taking. What the enhanced best fit sphere does is that it excludes the central 3.5 millimeters around the thinnest point of the cornea. So you're excluding the central data points and using more of the peripheral data points to give you the enhanced best fit sphere. So any central protrusions, so most often keratoconus starts in the central or paracentral cornea. So within the central 3.5 millimeter, if there are any focal protrusions, this gets highlighted as a red flag sign, something for you to look at. So this is what it does. So essentially, this is the normal elevation data. This is the reference sphere after the central 3.5 millimeter has been excluded. And then this is the difference between the two scans. And even that is color coded. Where there is a certain difference which is permissible, like up to 5 or 5 to 7 microns on the anterior surface or 12 to 15 microns on the posterior surface. But any difference beyond that is considered a red flag sign. Apart from that, you have the CTSP or the corneal thickness spatial profile. That is, your corneal thickness varies from the central to the peripheral cornea with the way it is progressing. If there is a sudden decrease or a sudden shift, then it goes beyond the 2 standard deviation values which are there. Again, similarly, your cornea has normally a symmetric increase in the percentage thickness as you go from center to periphery. And when there is an alteration in that, again, it goes beyond the 2 standard deviations. Finally is the differential values. You have the differential values on the front surface, DF, on the back surface, DB, for pachymetry, DP, the thinnest point, DT, and then the displacement of the thinnest point from the center, or the axial displacement from the center, which is dy or dA. So these are just again differential values, again to show you the deviation from normals in a more highlighted, easy format for you to be able to diagnose doubtful cases, early suspicious cases before you take them up for refractive surgery. Again, just a quick close final example of a thin cornea versus ectatic cornea. You can see that the patient's thickness is only 460 microns. In isolation, 460, you might think it's a thin cornea. But as you can see in the curvature, it is absolutely symmetric. You see the elevation data, it is completely normal. Whereas another patient, you can see here, there is the same thickness of 460 microns, but there is a significant IS asymmetry, there is elevation on the posterior float, and you have the differential values which are very much in red. So these are just some pointers towards looking at a map. An isolated IS asymmetry, when everything is completely normal, you should also see how the patient has been imaged. So there is something called a displaced apex syndrome, that is when the patient is slightly looking up. So what happens, instead of imaging this central cornea as the center, you might start imaging the slightly inferior paracentral cornea as the center, because of which you may have a significant IS asymmetry. And this can be ruled out by repeating the scan, refocusing, and usually it goes away. So thank you so much for your attention, and I'd be happy to clear any doubts. So it's my pleasure to introduce our next speaker, Dr. Sangwan sir. Sangwan sir is, there's some introduction which Rolika is passing on, but it's just that Sangwan sir goes way beyond all the introduction lines which are given here. He's been a teacher and mentor for many of us over the years, and I have had the proud privilege of doing my fellowship under him 11 years ago. And he's not just taught us cornea and ocular surface, but people who are close to him have learned a lot of things from him, life lessons, your patient skills, listening skills, and recently over the last few years about fitness and other things as well. So he never fails to inspire and continues to inspire generations, and I'm sure you'll enjoy the next 45 minutes of his session. Over to you, sir.
Thank you very much. All right. Good morning. Ocular surface disease, we'll talk very briefly about what it is and how you can manage. It may have, you may think about the questions for your theory and viva. I may not be able to give you the tips about how you are going to answer the question, but this is an introduction. Ocular surface essentially is part of the eye which is facing the environment, right? So it is consists of the preocular tear film with all its components, the surface epithelia, essentially the corneal epithelium, limbal, conjunctival epithelium, and the ocular surface sensitivity. It is different than the corneal sensitivity. So cornea is part of the ocular surface, and the, any perturbance or any problem with these elements leads to ocular surface disease. The first element of the ocular surface defense are the preocular tear film, which have compositional factors and hydrodynamic factors. And I'm sure you will read about and you will listen quite a bit of talks about the dry eye and the preocular tear film assessment. Tulika was talking about how do we assess the ocular surface staining and all the cellular test and other things. As a disease process, you should understand the neuroanatomic integration of the ocular surface happens at the mid-brain level. And there are two reflexes controlling this, the lid blinking and the tear secretion. And there are two different pathways which are controlling that. So if you remember this, then you will be able to understand that this is the dry eye or the ocular surface is basically like any other organ controlled by the midbrain. Another element in this is a stable tear film is essential for the healthy ocular surface, meaning all the epithelia. In turn, the healthy ocular surface epithelia are essential for the tear film. So there is an interdependence, right? The ocular surface disease spectrum consists of a variety of things. So we'll not be able to talk about everything today. You have the VKC, you have Moran's ulcer, you have injuries, chemical burns, you have mebomyitis. So all these and limbal stem cell deficiency, which we'll talk towards the in the second half of the talk. The questions you need to answer, the surface disease which you are dealing with, is it do you need a medical treatment or a surgical treatment, right? So the picture on your that side, left side, is the essentially a Moran's ulcer, and right side is the chemical burn. So if this Moran's ulcer patient comes at the end stage and also it is total damage, ocular surface vascularized, and if you don't take the history, and if you don't understand what is underlying, and if you intervene surgically, your outcome is not likely to be good. So it's important to differentiate what is the underlying disease for ocular surface disease. That's ocular surface disease is not a disease itself, right? There has to be something underlying it. Another element or important concept is that we need to understand if the surface is dry or wet. If you have a completely dry surface, like in the Stevens-Johnson syndrome on the video clip which you are seeing, on the wet surface on the right side, which are mostly chemical burn. So if you treat the ocular surface with the wet eye, the chemical burns, your prognosis of the condition is likely to be good. If it is a bone dry, like in OCP or Stevens-Johnson, you will not get a good outcome if you do surgery. Say, for example, you attempt to do a amniotic membrane transplantation or a limbal transplantation. In these conditions, it won't work. So it's important to understand that the immune-mediated disease need a systemic treatment, right? Not just the surgical aspect or not just the tear substitutes. Another consideration, whether your condition which you are dealing that needs a medical or surgical treatment. So these two videos, which are, one is mebomyelitis, the other is rheumatoid arthritis with ocular surface with thinning. The other is ocular surface neoplasia. So the OSSN is primarily a surgical disease, right? You need to exercise, and then nowadays we do primary slat in that, or you do medical treatment following that with chemotherapy. The mebomyelitis needs purely a medical treatment. Rheumatoid arthritis needs a systemic treatment along with the medical or topical treatment. Here is a case of a software engineer who presented with the acute onset of red eye with discharge stickiness and foreign body sensation. And when we looked into further, we thought that it's adenoviral conjunctivitis, but there were some oral lesions. What do you think what it might be? Kya lagta hai? Is it still adenoviral, or somebody said Bassett's disease? What else? What could be a more differential diagnosis? Reuters, okay. Or kuch? Or anything else? Candida infection? It doesn't look like that oral thrust which you are familiar, but having bilateral severe conjunctivitis with some oral lesions, maybe you should think of the history, further history. So we basically started treating, and he had some sort of a biopsy or something done, and there was a, they suspected OCP. OCP, you know what it is? And the other name for that is MMP. So this patient, essentially, we initially did not understand what we are dealing with, and we treated with the topical treatment and systemic. And this is our revised diagnosis at that stage was that EM minor or a Stevens-Johnson syndrome. Erythema multiforme minor or a Stevens-Johnson syndrome, that you know this is a severe condition which involves the acute drug reactions, right? So this patient continued on follow-up and continued on systemic treatment as well as topical treatment. After 3.5 months, the eye has improved somewhat, but now we are seeing the cicatricial effects. So there has to be some sort of a cicatrizing process, either OCP or a Stevens-Johnson syndrome, right? So in conjunctivitis, you may get in acute, say acute adenoviral conjunctivitis, you may get a severe reaction, but very unlikely that it involves other mucosal surfaces. So finally, we also came around and thought that this is a mucous membrane, and we had a biopsy, repeat biopsy, which showed that this is a patient with MMP, which was well controlled on systemic methotrexate, and we had given IV intravenous methylprednisolone as a pulse cytoxone and used Pro's lens or a Boston scleral lens, and this was proved with the biopsy. So what is the, how do you do biopsy? Have you seen? Does anybody have any experience of seeing it in your institution or only read about it? In brief, OCP is a chronic cicatrizing conjunctivitis. It's a immune mediated, and it's a very potentially blinding disorder. Why? Because these blisters causes scarring and inflammation, and over a period of time you develop symblephrone and other problems and corneal loss of corneal transparency. And this is just how the pathogenesis is, and this is how you do. This condition is diagnosed with immunohistochemistry or immunofluorescence, apple green kind of color at the basement membrane. You are seeing the biopsy being taken under local anesthesia, and then you put it in OCT, this is a freezing medium or a embedding medium, and then put in the liquid nitrogen, and in the laboratory you do the sectioning and then the staining, and what these green slides, what you are seeing is the interpretation, and that is how you do the diagnosis of this condition. What is this? Is this something VKC you have seen, such severe VKC? Do you treat with topical or systemic treatment? Only topical? Anyone? बोल दो, कुछ नहीं होने वाला. See, if you have a severe condition like what you are seeing here, so I'll show you some more pictures. If you have pictures like this, in these patients, topical steroids or topical treatment, mast cell stabilizer won't do anything. Agreed or not? What is the problem? Here you are seeing a very severe limbal VKC. What will it cause if there is a persistent inflammation? Limbal stem cell deficiency. And once limbal stem cell deficiency sets in, you are basically blind, and only treatment will be surgical with systemic steroids, immunosuppression, and a limbal allograft. And then it changes the whole equation. So therefore, do not think that, okay, you can treat these patients and save their cornea only by topical treatment. I treat most of the moderate to severe VKC patients with systemic steroids and systemic cyclosporine. So, and the results are very good. So you have to be a little more familiar. I'm not going to talk about systemic immunosuppression, the medications, and it can be a question for, in theory and also maybe in viva. But generally, if you are prepared, I think you can answer much better. But mostly, I don't know in medical colleges, do people use systemic steroids or systemic medication for eye condition. I don't know. And at my time, when I was PG, nobody used to use. Is that the case still, or somebody is using? Using. Okay, good, some change. Another patient I'll share with you. This is a patient I had managed in 2001, just joined LVP a few years before. And this patient came from Rajasthan, had a history of pterygium surgery, and then you look at the presentation. Do you know what it is? What do you think what it is? Diagnosis bolo bhai. Anyone? Scleromalacia nahi hota. Scleromalacia is a condition which is not active. Scleromalacia is thinning of the sclera, right? Due to repeated inflammation, rheumatoid arthritis, any other scleritis, necrotizing scleritis. This is called SINS. What does SINS stand for? Surgically induced necrotizing scleritis. Why? What is unique about it? You will, at the site of surgery, you may find lesions like there is a there's necrosis of sclera, but away from the site, you are seeing there are inflammatory nodules. So a necrotizing scleritis is, it's like a microvasculitis of the conjunctival vessels and episcleral vessels. So it will cause inflammation not only at the site, but away from the site also. And this can happen after following any surgery. So the treatment for this condition, will you do systemic treatment first, or a scleral patch graft, or nothing? Scleral patch graft. First systemic, okay, very smart. First we do, in these eyes, we should treat them systemically, because if you, in the acute condition, if you are trying to do a patch graft, this will not work. So this particular patient received intensive systemic steroid, cyclophosphamide for 6 weeks, and then what you are seeing the video is a scleral patch graft after hooking the medial rectus muscle, which I would detach, and then put a large scleral patch graft. Generally, when you have this kind of a scleral necrosis, it will be going beyond the muscle insertion also sometimes. So in this case, we need to remove and then check, and then your graft comes in place. This patient continued on systemic cytoxin for almost a year, and further he underwent a cataract surgery in that eye and achieved a vision of 20/25. So therefore, when you see with such severe complication, does not mean that that's the end of the world. And if you manage them properly, hopefully you will be able to restore good vision. Now, what are the surgical options if you have seen a patient, and what are the surgical options or the treatments for ocular surface disease? I'm primarily going to talk about two things: amniotic membrane transplantation and the limbal transplantation. And so that means mostly it will be surgical and tips for these different indications. So amniotic membrane transplantation, the indications, this can be a question for your theory. The indication, contraindication, surgical techniques, outcomes of amniotic membrane transplantation for various eye disorders. And this is not the complete list, but for anterior segment, this is primarily includes everything. And there are multiple indications. Now we use for persistent epithelial defect, especially if it is sterile, conjunctival defects following pterygium surgery, OSS and excision, acute chemical burns, limbal stem cell deficiency, and also used for growing the stem cells in the lab. This is the video where we use the amniotic membrane as a substrate for growing the stem cells, which we use to do cultivated limbal epithelial transplantation, and also still we use for understanding the biology of the limbal stem cells. We still use. So why the amniotic membrane is so good about a variety of things? It's because it's essentially a very thick basement membrane, consists of different kind of collagens, fibronectin, laminin, and it helps, enhances the epithelial cell proliferation, migration, and adhesion complex formation, and also it has a avascular stromal matrix, therefore it suppresses TGA beta and other signal, reduces the inflammation. So this can be a question for your theory exam. Now, how do you use the amniotic membrane? So the processing and all that I'm not going to cover. That is provided mostly in the eye, from the eye bank. What you are seeing here is a suturing with 10-ohm monofilament. So what you are seeing here is that sutures should be put circumferential and hold so that it can hold the amniotic membrane in place. And I'm trying to show that you should not come out beyond the edge of the membrane, because otherwise your membrane will crumble. So you should come out the edge of this membrane so that it can hold, just what you have seen in the video. These things you will see further. My more recent, or for last maybe not recent, 15-20 years now, I have been using the fibrin glue. It is available easily, and this makes the surgery much more easier and more predictable. So here what you are doing is, I'm doing in a patient, probably it's a VKC patient with the pannus. I'm removing the pannus and replacing it with the amniotic membrane and with the fibrin glue. So after you clean up and do little cautery, then you can have the fibrin glue component A and B put on ocular surface and mix it on the ocular surface itself. And no need to use that Duplojet syringe which comes with the product. And then you bring the amniotic membrane, spread it across, without any wrinkles, and cover the conjunctival defect also, and then you trim excess membrane, and you don't need to little bit iron out so that the membrane sticks nicely, and that's the end of the surgery. How do you use in acute chemical burns? Very useful, very, very useful, and we have published 2-3 papers in 2006-7. Here, any graft you do in the human body, not only in the eye, it has to be a de-epithelialized surface, right? If you put a graft on an epithelialized surface, it won't work. It cannot be taken up. So in acute chemical burn, you remove all the dead and necrotic tissue, dead necrotic conjunctiva. And how do you know conjunctiva is dead or not? When you are cutting, if there is a bleeding, that means there is a viable tissue. If there is no bleeding, that means it's a dead and necrotic. So you keep cutting until you induce bleeding. And like in this patient, what we did was we removed not only this part, but and the upper half also. So you do a 360-degree peritomy because it's involving more than 2/3 of the limbus. Then, and use tenno monofilament, or you can use the fibrin glue. Right, so you cover the ischemic area of the conjunctival side also, and you see how these perilimbal sutures are used. Sometimes you may have chuna, which is retained on the cornea, and I have seen quite a lot of patients. So here this chuna keeps migrating into the cornea, and then this patient is about 2 months post chuna injury. So what we are doing is we are making a 360-degree peritomy, and then do little bit of cautery, and this chuna part will remove by lamellar dissection. What happens if you leave the chuna in the eye? What will happen? This side. Anyone from this side? What happens to the chuna if you leave in the eye? Chuna will keep migrating inside, and it keeps releasing the chemical, and which will destroy the eye. You will not be able to salvage it with any method. So that is a kind of an emergency, and I'm sure Uma will talk about these things in her talk. This is how you do the amniotic membrane, and these are the examples of using amniotic membrane. I use in bullous keratopathy. If I am doing an ASP, anterior stromal puncture, I combine with the amniotic membrane, remove all the loose epithelium, then put the membrane, and through the membrane I do ASP. How you do in sealed ulcer? Sealed ulcer, this plaque you need to remove. It's not, just scraping it won't come. It's a very tough membrane adherent on the base of the ulcer, and then after removing it with surgical blade, you put either sutures or the fibrin glue. So here the sutures I am not putting in the mid periphery or in the center of the cornea, because if we put sutures there in a normal cornea, we will create scarring. So we are putting only in the periphery. This is another sealed ulcer, and you need to remove the as much as loose and necrotic epithelium. Have you used supratarsal steroid injections? Does anyone do? Mostly when I am doing amniotic membrane transplantation or sealed ulcer, I also give it to supratarsal steroid injection, triamcinolone or methylprednisolone. So now that was the surgical part of the amniotic membrane transplantation. Now we'll talk about the limbal stem cell transplantation. So limbal stem cells, how do we know they are located at the limbus? There is enough amount of evidence in the literature that it is on the limbus, because if the limbus is destroyed, then we see the conjunctiva grows onto the cornea. So the function of the limbal epithelium is, number one, barrier function, and number two is regeneration of the corneal epithelium. And we know that, what is the XYZ hypothesis? Richard Thorpe and friends XYZ hypothesis. That's essentially now is no longer a hypothesis, it's proven in the labs that the limbal stem cell exists on the corneal limbus, and then they reepithelize the surface. If the limbus gets damaged or diseased or dysfunction, then you get a condition called limbal stem cell deficiency, which is characterized by ingrowth of the conjunctiva onto the corneal surface, which leads to chronic inflammation, recurrent epithelial breakdown, and loss of vision. Right? There are different ways to classify. There can be a question, classify what is limbal stem cell deficiency, describe classification and its treatment. So here a brief classification, primary versus secondary, or acquired versus congenital, immune mediated versus rest other. There are multiple classifications which exist. In here, you are seeing examples of focal stem cell deficiency. This is VKC, this is Murran's ulcer, this is chemical burn. The only treatment of the limbal stem cell deficiency is the limbal stem cell transplantation, and the classification of this procedure can be based on the source, allogenic versus autologous. What is allogenic? बोलो भाई, तुम तो बहुत बोरिंग. क्या भूख लग गई क्या? अभी तो लंच में टाइम है. What is allogenic? From the same person or from the? And if it is from another species? Genotransplantation, yes. So for allogenic, it can be live related or cadaveric. We have done limbus. I'll show you the technique of doing cadaveric versus live related. Autologous can be ipsilateral or contralateral. What is ipsilateral? Good. Surgical technique wise, there is a direct, meaning that you transplant the tissue from the same eye or the other eye of the same person or from the donor and transplant directly, like corneal transplantation. Or you do a ex vivo cultivation. Ex vivo cultivation means you take a tissue, take biopsy, send it to the lab, culture, and then transplant. And now we have another technique called simple limbal epithelial transplantation, wherein we grow the cells on the surface of the eye using the eye or the cornea or the eye as a petri dish. So this is the rationale. If you have a patient with limbal stem cell deficiency, can you do a corneal transplant? Will it work? Why it won't work? क्यों बोलो क्यों नहीं काम करेगा? No blood vessels. We thought no, the limbal epithelial cells do work, right? Barrier function and regeneration of the corneal epithelium. So donor epithelium on the cornea survives for how long? When you would do a corneal transplant, say for keratoconus, how many weeks it takes for the donor epithelium to be replaced with the recipient epithelium? Yes or no? Does it get replaced or no? How much time does it take? How many weeks or months? 1 to 2 weeks? नहीं. देखो ये बहुत important trick question है, why में पूछा जा सकता है. ठीक है, कोई तो तुक्का लगेगा. So you need a corneal epithelium from the recipient. So if patient having a limbal stem cell deficiency, corneal transplantation is not an answer, because the recurrence of LACD will happen within few weeks. So therefore, you need to treat that deficiency by some limbal transplantation, whether you do direct or whether you do a allogenic or cultivated or whatever the technique, which we'll show you. So the technique of direct limbal transplantation, as shown here, is you take a segment almost 2 to 3 clock hours, and if it is a total, depends on how much is the deficiency in the recipient eye. But if it is a total deficiency, you generally need 6 clock hours from the donor. And I used to take 2 donors, 6 clock hours from one eye of the one donor, and 6 clock hours from another donor of the same family. This is a patient who I have seen very early in my career, 2000. At that time, I just started doing the cadaveric limbal transplantation. So this is how you harvest the limbal from a donor rim. And after that, you will clean up the pannus and suture it in place. And you will use, since it is a limbal allograft, you will use systemic immunosuppression or no? Allograft needs systemic immunomodulation. Like kidney, liver transplants, the limbal allograft needs a systemic. If you give only topical, it will not work. It will fail for sure. So this patient did well, and after the limbal transplantation, we did a corneal transplant, cataract surgery, and she regained reasonably good vision for some 2-3 years, and then she had a rejection, which was treated with IV methylprednisolone, and she was already continuing cyclosporin, tablet Imuran, that is azathioprine. And why she was getting diltiazem tablet? Anyone? I was also giving the patient diltiazem. What is the role of diltiazem if you are using a immunosuppressives? How does it help? Anyone? It's MBBS question. लंच के टाइम में कोई भी मुझे इसका जवाब देना, मैं अभी नहीं बताता. The problem with cadaveric or any kind of allograft is that you needs immunosuppression, and immunosuppression is very costly and potentially have side effect. And to give you the idea of the cost, 1 milligram of cyclosporin is 1 rupee. And if you put all the medications, it will be around 5 to 6,000 rupees per day, no, per month in the maintenance, 10 to 12,000 in the first 2 months. So it becomes very expensive to maintain. If you are using cadaveric cells, we don't know our limbal epithelium is viable or not, because corneal storage media are designed for endothelial preservation, not epithelial. And also the growth potential of the cadaveric limbal epithelium is around 43%. And if you take live related, it is 100%. Because if you take the live tissue, it will definitely grow. And that we have shown in the lab. Now I'll show you a patient of how we do live related limbal transplantation. It's a patient with chemical burn with bilateral limbal stem cell deficiency. So as I told you earlier, we take the limbal biopsy, 2 donors, 3 clock hours superior, 3 clock hours inferiorly, and I have 4 biopsies from 2 donors, and then you harvest like this conjunctival limbal allograft, and after that you remove the pannus, clean up, and then you suture them and basically put amniotic membrane, and on top of that you put these lenticules. This is a patient's appearance. This received the graft from 2 donors, from mother and father, and he did well for many years with on immunosuppression. Right? The post-op management will be systemic medication, as we discussed, at least 3 medicines, the steroids, azathioprine, and cyclosporin. Then the question comes whether you use direct or cultivated. What's the downside of the direct? Because if you are using direct, there is a large amount of tissue we need, and that can create deficiency at the donor site. So that this has been well reported in the literature in 2000 and in early 90s and 2000, that the patient where you take the biopsy, not everyone, but small percentage do develop iatrogenic stem cell deficiency, and these are different papers at donor eye complications and donor eye. These are, if your biopsy is badly harvested, you can create the normal eye of the donor gets damaged. So to circumvent that, the cultivated limbal epithelial transplantation came in being, and see how you harvest the limbal biopsy. The first video is in the YouTube available in 1989 by Sefer Singh and Kent Canyon. They started harvesting the biopsy from the corneal side. And fortunately for me, I never saw this video until 5-7 years back. I did not think that is a good idea. I started harvesting from the other way around. See, from here what you are able to see is you start from the conjunctival side. If you come from the conjunctival side, what is advantage? It gives you natural anatomical landmark. You know how the conjunctiva looks, how the sclera looks. In between there is a tenon's graft or tenon's capsule. So you harvest the tissue from this side, because then you are able to maintain the plane properly. So this is the advantage of cultivated limbal epithelial transplantation, which we started around 2000, 2001 in LVP. And we used to take a small biopsy, send it to the lab, and then grow for 2 weeks, and then transplant back. This is how you do the cultivated limbal transplantation. It shows this is the scheme for cultivation, and this was a explant culture using the particular corneal epithelial culture medium. After you remove the pannus, you bring the cultivated cells. This is the cells which are grown in the lab, and then you transplant. And we did this for many years, almost 10 years. The advantages of cultivation are listed here. You need a less donor tissue, no donor site complication. It's faster epithelialization. Faster epithelialization because you are already putting a sheet of epithelium, right? And then faster resolution of inflammation, less scarring, and also it seems there is a amplification or there is a multiplication of the stem cells, and that therefore long-term survival. We published extensively very large series in the peer-reviewed literature with a success rate of 75%. And these are the essentially, in IJO, 526 eyes. Then we started realizing that there is a problem with the CLET, is that it does not really work well in a pediatric LSCD, which we highlighted in the literature. And also, growing the cells in the lab is very expensive, and it takes 2 weeks. For one surgery, patient has to come twice, right? So this was becoming a problem, and it can be practiced only in big centers. If you are practicing, say, in a smaller town, how do your patient access this? So it essentially was not accessible technology. So then we developed something called simple limbal epithelial transplantation, and this is shown in this video very briefly. After harvesting the biopsy, you dissect the pannus, start from the periphery, you go all around dissecting the pannus, and then clean up the surface, find the plane. Here our goal is not to remove the corneal fibers. Our goal is only to remove the fibrovascular pannus. Then fix your membrane with the fibrin glue, and then you cut your explants or limbal pieces arranged on the ocular surface. You will see in this short video, and you will get this video and the whole lecture as a handout. So after this, remember, we are tucking this membrane all around on the corneal and bulbar surface. Excess membrane will be trimmed, and then you put your explants, and then one layer of the fibrin glue, both components, and on top of that you will put the bandage contact lens. And if it is a autologous slat, then you need only topical treatment. If it's a allo slat, then you would systemic and topical treatment. So these are the small biopsy which we had harvested and kept in the ringer lactate on the surgical trolley. And these pieces can be arranged nicely. It is the art part, how you arrange these on the surface, equidistant, and just 2-3 millimeter inside the limbus and mid-periphery. And on top of that, you will put the fibrin glue. So after this, it is being arranged all around, and fibrin glue will be distributed, put very tiny drops. So what you can expect after this is a patient, what is this appearance called? What do you say it? What is the spot diagnosis? What the picture is with tomato? It's a patient with acute chemical burn, healed. What do you call this? No one? Brain ka hypoxia ho gaya. This is called pyogenic granuloma. Pyogenic granuloma. So this surface, what you are seeing the top and on that side, this is the same patient before and after slat. And these are the same before and after. So what the slat is essentially, if you evaluate these 3 surgeries, conjunctival limbal autograft, the cultivated limbal epithelial transplant, and simple limbal epithelial transplant, evaluate in those 7 parameters. This technique, slats, is either better or as good as other techniques, and essentially it has eliminated the downside of SCLAW, conjunctival limbal autograft, and also of the CLAT. So it combines, it is a small tissue grown in the eye and one surgery, single stage surgery, patient doesn't have to come, and you don't need a lab. And you can do surgery wherever you are after learning it. And above all, it has reduced the cost of surgery to only 1/10. Say if it was around 7,000 cost in US dollars for CLAT, so it may be around 700, even if you charge well. In Europe and in America, there is a technique called Ocular, and it costs about 85,000 euro, which is quite a lot of money. 85,000 euro will be more than 80-90 lakhs for one surgery. So the difference between CLAT and SLAT for your on understanding, and maybe this may be sometimes in your exams. SLET is a one-step quick procedure. CLET is two-step procedure. SLET does not need a lab. It is replicable. It is less expensive. No blood products. No risk of contamination. No culture-related risk. So essentially, all these are the advantages. And these are some of the outcomes and difference. So in summary of this SLET this is effective, replicable, repeatable, affordable, reliable, and a very open platform. It's not patented by anyone. So any surgeon, now there are at least 6-7 innovations already published on SLET. Thank you very much. If there are any questions, I can answer, or are there any questions? Thank you very much.
Thank you very much, sir. It is such a wonderful talk for all of us, and I must say that we all learn SLET from Dr. Sangwan, and it's always a pleasure having him around and listening to him. And beautiful talk. I hope you guys enjoy his talk. And I'm privileged to invite our next speaker, Dr. Uma Sridhar, ma'am, who is well-renowned cornea surgeon, India and overseas. We all learn from her. She's the head of cornea in eye care at Noida. Ma'am, may I welcome you please for the talk. She's talking on evaluation and management of acid-alkali burns, and we are here to listen to her. Thank you, ma'am.
So before Uma ma'am takes up, there's something interesting that is coming in this session. What you all have to do is take a small paper. You guys have received the notepads, right, in the delegate kit, right? So take out a small paper, write your name on top and your delegate number on top, okay? So Uma ma'am has made this session extremely interesting for all of you. So she will be taking up questions in between. So there are 6 questions, 6 MCQ questions that will be coming up in the middle of her talk. You have to write down the answers, A, B, C, D, E, ma'am, right? A, B, C, D, E, F. No, 6 questions are there. No?
So question 1 to 6 will be 1, 2, 3, 4, 5, 6.
Right.
And A, B, C, D.
Okay, fine. So there are 6 questions. So your answers are like A, B, C, D. So you have to write down 1, 2, 3, 4, 5, 6, and then just keep some space for the MCQ questions. And once the session is, once ma'am declares a 6th question, and once her talk gets over rather, so that we don't disturb ma'am, all of you have to send the picture of your paper to me on WhatsApp, okay? Don't send it individually, send it on the group, flood it on the group, okay? But it will be taken out only after ma'am finishes for 3 minutes, that's it, okay? After that, whoever wins gets a book that ma'am has bought from you guys. There will be one person, and anybody who, if there's a tie on the first position, a lucky draw will be picked out, okay? So, and all the offline people, the people who are watching it online, sorry, I cannot provide that version for you. So please don't send me WhatsApp messages, how much ever I would love to receive them. Okay? Got it? Over to you, ma'am.
After that wonderful talk by Dr. Sangwan, I think it's a hard act to follow. So we'll be talking about chemical injuries. You may see a patient like this, not treated properly, will end up like this. Of course, we can send them to Dr. Sangwan for a Boston K-Pro or a Oro K-Pro or something like that, but we don't want them to reach this stage, right, or this stage. So chemical injuries are a true ocular emergency, and it could be 7 to 18% of all ocular trauma, if not more. They can produce extensive damage to the ocular surface epithelium, cornea, and anterior segment, resulting in permanent unilateral or bilateral visual impairment. And 80% are due to industrial or occupational exposure, hence males more than females. And Lyme and tuna injuries are very common. So it's not just all these various products that can cause chemical injury. You should also be careful about the eye which falls into the eye, or there's a lot of homeopathic stuff which people are putting into the eye, and that is causing chemical injury of various grades. So here you have cleaning solutions, drain cleaners, bleaches, and cement and acid. And specifically in industrial areas, you will find all these ammonia, lye, potassium hydroxide, and lime. And acid burns sulfuric, sulfurous, hydrochloric acid. So where do you find these various acids? Sulfuric and battery acid. A lot of our patients come, they were cleaning their cars and then the battery exploded. So luckily for them, it's not such a severe injury, it can be managed. You also have ammonia as a refrigerant and cleaning agent, which is quite severe. Acetic acid, of course, home cooks will know vinegar, glacial acetic acid, drain cleaners, and also those working in the lab. You have a lot of microbiologists, pharmacologists, students coming to you with bleach and refrigerants. And you also have hydrofluoric, which is quite severe. So the severity of the injury depends upon the type of chemical, the volume of chemical, the concentration, and the duration of exposure. So before we go into pathophysiology or anything like that, at-site wash is very important. So which solution do you use, how long, and how much of that solution? So my first question would be, which is more effective? Option A, tap water, more than ringolactate, more than BSS, more than diphotherine. Option B, diphotherine, more than ringolactate, normal saline, BSS. Option C, diphotherine, BSS, ringolactate, normal saline. Option D, phosphate buffer solutions, diphotherine, BSS, and ringolactate. So this is your first MCQ. We'll get the answer further down. So at site, whatever solution is available. Tap water is the most common available, but it is hypotonic and it can cause swelling of the corneal stroma. Normal saline, ringolactate, BSS, and polyvalent amphoteric solution, diphotherine not really easily available. Normal saline and ringolactate are cheaper than BSS. BSS is pretty costly. And the irrigation solution, like we said, tap water, ubiquitous availability in the field, it is cost effective. Buffer solution can correct the pH, but can cause a little bit of hyperthermia. And normal saline and BSS can give more patient comfort. Diphotherine is hypertonic, higher hyperosmolarity, and if readily available, is one of the better solutions. You have something called a Morgan contact. And otherwise, you can keep the patient, you have to put anesthetic drops, proparacaine, make the patient lie down, and you can keep a speculum also, and keep collected to a ringolactate bottle, wash thoroughly at least for 30 minutes. And you have to keep, if you have filter paper available, then you can, not filter paper, pH paper, you can keep checking with the pH paper every 20 minutes. My MCQ is, the alkalis penetrate more because A, acid saponification of cell membranes, B, alkali saponification of cell membranes, C, acid coagulation of epithelial proteins, and D, alkali coagulation of epithelial proteins. So this is the second MCQ. Now the MCQ 3 is, which alkali is more severe? Sodium hydroxide, more than calcium, this is in the decreasing order that you see. That is KOH is the least, after that ammonium, then calcium, then sodium. The second B is, the least is ammonium, then sodium, potassium, calcium. The third one is calcium is the least, then potassium, sodium, ammonium. Fourth one, the least, this one is calcium, then ammonium, sodium, and potassium. I hope you got that. Right. Now the pathophysiology. How does the acid affect? Acid causes denaturation and precipitation of proteins on contact, causes a ground glass appearance. There is a barrier to further penetration, and there is a damage to the stromal matrix. But if it is a very severe acid like hydrofluoric acid, it can still penetrate. It can be as bad as alkali. Alkali causes saponification of fatty acids in cell membranes, causes rapid penetration, and damages to deeper structures. So they dehydrate the cells, cause enzymatic and destroy the enzymatic and structural proteins. Ammonium hydroxide causes rapid penetration, followed by sodium, potassium, and calcium. And there is also a thermal reaction. In cracker injuries, like magnesium hydroxide, you have thermal and chemical injuries. Now, the ocular response to chemical injuries. You have seen from Dr. Sangwan's videos how he has treated them, but what has caused the damage? The conjunctiva gets cauterized, the corneal epithelium sloughs, the corneal stroma swells and opacifies, the endothelial cells die, the angle structures scar, and the lens opacifies. The ocular response further is, the weak acids and alkalis may just cause injection and chemosis and corneal clouding and edema. So when you see the battery acid injury or when you find some chemicals have fallen into the eye, there may be just a lot of chemosis, there may be corneal clouding and edema. In severe cases, the cornea and conjunctiva are white and opaque. So red is necessarily a better thing rather than white. Nitric and chromic acid, tissue becomes yellow-brown. Severe acids, they cause corneal anesthesia, limbal pallor, and uveitis. And severe alkali can cause corneal melting and perforation in 2 to 4 weeks. The extent of limbal injury is important for re-epithelialization. So the fourth MCQ is, what is the most important prognostic factor immediately after ocular chemical injury? A, chemosis. Second, conjunctival epithelial defect. C, limbal ischemia. D, corneal epithelial defect. Now, the clinical course of chemical injury, as we said, the pH is important, the concentration, and the length and the time of contact. So what are the clinical course? It could be immediate, acute, early reparative, and late reparative. So the immediate, as we said, you have to wash, wash, and wash. We'll come to that later. The acute phase in the first 7 days, you want to re-epithelialize. It doesn't matter it's corneal epithelium, conjunctival epithelium, or what epithelium, but there should be an epithelium. Otherwise, the underlying stroma will melt. Control of ocular inflammation is the second most important therapeutic consideration. Also, look at the corneal clarity, the intraocular pressure. You may not be able to check it with NCT or something, so digital pressure or tonopen might be useful. Shrinkage of ocular collagen, and later due to release of prostaglandins. These are the two mechanisms for raised intraocular pressure. In the early reparative phase in 8 to 20 days, there occurs a chronic inflammation, stromal repair, and scarring. And here the goal of treatment is the establishment of intact epithelium and to control inflammation. Whereas in the late phase, there would be loss of corneal sensation, reduction of blink reflex and decreased tear production, severe injury leading to pannus formation, and here you have to maintain the epithelialization, lubricate the ocular surface. What are the prognosticating factors? The total area of epithelial defect of the cornea, of the conjunctiva, the number of clock hours of limbal blanching or ischemia, the area and degree of density of corneal opacification, evidence of raised IOP on presentation, and loss of lens clarity. The last two elements imply deeper effects of the chemical agent and damage to the inner structures. So how do you evaluate the patient? These pH strips are easily available on Amazon, and we have also started keeping it. And the reason we started keeping it is an interesting scenario. We had an elderly lady who was one-eyed and came with, she said, was getting treated for conjunctivitis. I don't have pictures of her eye. It looked like she had chemical injury, but there was no history of any trauma of anything. So we did an amniotic membrane of her eye and of the cornea and of the lid. And then later we said, okay, you get admitted in our institution and change the eye drops. She started improving. Then she went home, she again deteriorated. Then when she came back to us, then we got these pH strips, we checked her eye drop bottle. You can see here, the acid will give a color of pink or red. All her eye drops were giving a color of red. So we just asked her, some family member was putting the eye drops and they were all contaminated. So this is how we got to know that it was an induced chemical injury in her eye. So this is good to keep this, and if you find any of your patients who are not who are having a severe problem with even preservative-free eye drops, just check the pH and to see if they are spoilt or not. This is easily available, right? Now here, this is one way we have an octa, but the octa does not show the anterior segment. So here you can see that there is no blood vessels here, but after tenoplasty, you can see the blood vessels have formed. So this is an interesting way of knowing about scleral ischemia. There's another software by one of my colleagues, Dr. Bhaskar Ray Chaudhary, who has done, probably it will be available soon, where you can take the pictures of the eye, put it through the software, and you'll get a picture like this to see where the blood vessels are. So actually, the limbal ischemia is something which we think that we have, if you see a white eye, you should not be happy. It's better to see a red eye. But if you see localized hemorrhages, they are signs of limbal ischemia. The clinical picture will vary in the first time when you see the patient and as you go along. So the classification systems are very important. First, we had Hughes in 1946, and then Ballon in 1963, whose classification was modified by Roper Hall. Now, what are the different classifications? My fifth MCQ is, Dua's classification is based on cornea, limbus, and lid, cornea, limbus, conjunctiva, and lid, limbus and conjunctiva, or limbus, conjunctiva, and lid. This is the fifth MCQ. Now, the classifications are based on total area of epithelial defect, corneal and conjunctival, the number of clock hours of blanching, area and degree of opacification, evidence of IOP, and loss of lens clarity. So the RAL classification gives prognostic scores of 0, 1, 2, 3, like that. So perilimbal ischemia score of 0, hyperemia score of 0, chemosis of 1, ischemia of 1, and so on and so forth. So the pupil, ischemia, epithelial loss, intraocular pressure, they are given various scores here. And also 0 to 3, they consider it's insignificant, heals very rapidly. 4 to 6 is mild, 7 to 9 is moderate, 10 to 12 is severe, and more than 13 is worse. The Hughes classification says mild, moderate as moderately severe and very severe. So the mild is erosion, faint haziness, no ischemic necrosis. Moderately, the corneal opacity blurs the iris details. There is ischemic necrosis, whereas very severe, you can see significant necrosis. Thorpe's classification again, all these are examination questions, so you should know the various classifications and what they say. Maybe you can't remember the details, but at least the names of the classifications. Thorpe is 1, 2, 3, and 4 with a prognosis of good, guarded, and poor. Poor showing cornea is opaque and you can't see anything inside, and more ischemia. Whereas the modified Roper Hall's classification is what caused Dr. Dua to modify. Like all of you know, the grade 4 Roper Hall may have actually good prognosis also in some of the cases. So the Dua classified the 4 into 4, 5, and 6. So when you find you can't see when the cornea is opaque, iris and pupil is obscured, and more than half of there is limbal ischemia. Harminder Dua's classification takes it as 1, 2, 3, 4, 5, 6. Good, very good, good, good to guarded, guarded to poor, and very poor prognosis, with clinical findings of limbal involvement, conjunctival involvement, and an analog scale. The analog scale records accurately the limbal involvement in clock hours of affected limbus divided by percentage of conjunctival involvement. And while calculating percentage of conjunctival involvement, only involvement of bulbar conjunctiva up to and including the fornices is considered. So here you find no area of limbal or ischemia or conjunctival involvement, less than 3 clock hours of limbal involvement, less than 30% of conjunctival involvement, more than 3, less than 6 clock hours of limbal, more than 30%, less than 50% of conjunctiva. Here you find 6 to 9 clock hours of limbal involvement, more than 50%, less than 75% of conjunctival involvement. Grade 5, you can see a similar picture clinically here. And you can see there are more than 9, less than 12 hours of limbal involvement, and less than 100%, but more than 75% of conjunctival involvement. Whereas grade 6 has all 12 hours of limbal involvement and 100% of conjunctival involvement in a case like this. Now it is an acute emergency, so remove the offending agent to promote epithelialization, promote corneal repair, reduce inflammation, control the IOP. Like we said, anesthetic drop, ask the patient to look in all directions, cotton-tipped applicator soaked in 1% EDTA to remove line particles, at least 500 to 1000 ml, of ringer lactate, even up to 3 liters. Avoid water, but you can't help it, use it. Diphotherine, pH of 7.4, osmolarity of 820, binds to acids and alkali, and then till the pH is in the normal range, use the universal pH indicator. Like Dr. Sangwan showed, debride the surface, the corneal conjunctival epithelium and some conjunctival tissue, so that the tuna or anything there is not leaching into. And the patient examination, see if you can see the patient under slit lamp, visual acuity if you can examine. See the facial skin, eyelids, lashes, lacrimal apparatus, and white eye is worse than red. Limbal ischemia, see clock hours of blood vessel loss or loss of conjunctival tissue. When you see total epithelial defect, you may not even see a staining because very faint edges will be stained. IOP digitally, instrumentally, posterior segment evaluation if possible. Medical management. Now here, most of you postgraduates are either junior residents or senior residents. And what will you do? You can't just call up your consultant in the middle of the night and say what you do. Before you take a history, just wash, wash, and wash. If you have pH strips, very good. Evert the lid. You can take a bottle with an IV and completely wash the eye. Evert the lid, double evert also. Then what is the treatment that you give that the next day your consultant does not give you scoldings the next day? So your tear substitutes with, now at this stage you don't use punctal occlusion. Preservative free if possible, but very frequently. Will you use bandage contact lens or not? This is a little iffy situation. I wouldn't recommend patching. If it is a large defect, patient is very uncomfortable and you can follow up, you can give bandage contact lens. Collagen shields, if available, is a good idea. Now the other drugs which are investigational like fibronectin, epidermal growth factor, retinoic acid, cord blood, amniotic membrane suspension, autologous serum, platelet-rich plasma, but none of it, you can be giving it at that point in time. Now, one most important thing that you will give is vitamin C. Vitamin C you can give as tablets. 2 gram QID is the ideal dose, but you can maximally even give 1 gram QID, but that is the maximum dose. Tetracycline, as we see, reduces collagenase activity. Also inhibits polymorphonuclear leukocyte activity. Collagenase inhibitors, if acetylcysteine is available. It can be available, but it may not be available in the middle of the night. You can give that. Autologous platelet-rich plasma drops may be at a later stage. My last MCQ is, what is the role of vitamin C? Decreases inflammation or promotes epithelial healing, prevents collagenolysis, or promotes collagen synthesis. So I think you can send your MCQs by WhatsApp. So there were questions. I had seen Dr. Merle Fernandez iFocus talk about 2 years ago. In fact, I saw it twice to understand, which was a wonderful talk with wonderful videos and all. So there were questions about preparation of ascorbic acid. 10% sodium vitamin C solution is available, IV solution. You can put it, you can empty a lubricant bottle and put it, inject it into that and give that if you can get it. Otherwise, give oral vitamin C. Sodium citrate. Sodium citrate, earlier one of the pharmaceutical companies had prepared it. I found it very useful to prevent perforation and thinning, but it is not available commercially. How you can prepare is you have vacutainers with blue top bottles. So in those vacutainers, you can put solution. It's about 3%. You need 10%. So you can say maybe 3 bottles and make that sodium citrate if you can, because it is very helpful, about 4 times a day. So how do you treat? This is an algorithm for acute chemical injury. Within 1 week of injury and delayed presentation, you will see patients at various stages. When there is suspicious areas of ischemia, you will give topical steroids. Now, one thing we as students, and even now when we see epithelial defects, we are a little wary about giving topical steroids, but no, topical steroids have to be given. Don't think of fluoromethalone or loteprednol, give prednisolone acetate. And how much of prednisolone acetate? Mild to moderate, 6 times at least. Severe cases, even hourly prednisolone acetate, and you will be following patients regularly. If it is grade 1, grade 2, important to grade 1, grade 2, follow up the patient every 2nd, 3rd day. Healing, you keep documenting the epithelial defect. If it is healing, continue same treatment. If it is not healing by the 3rd to 6th day, then you might consider amniotic membrane graft. Then if there is, like here you have seen sectoral ischemia, tarsorrhaphy, tenoplasty, and total ischemia, tenonplasty with amniotic membrane graft. Now here you are seeing the most important, which at your level as a JR or SR you can do, and how do you follow up is, every 3rd day you're going to see the patient, or every 2nd day if your OPD is there, document the epithelial defect. And you see grade 1, grade 2, just battery acid or something, it has started to heal, then okay, follow up, same treatment. Then again come back after 3 days, healed, very good. But it is not healing, grade 4, 5, and 6, you will need at the first situation an amniotic membrane graft, and you have already given corticosteroids, which decrease the 1st and 2nd way of inflammation, decrease collagenase production, stabilize the polymorphs, because you know the collagenases are what the polymorphs bring in, and that is what causes the perforation. And like we said, even sodium citrate prevents the polymorphs from coming in. So the polymorphs are the biggest culprit which come in, and some people are yawning, I'm sorry for that. Yeah. So then you also give, but this, I'm sorry, is an important topic. There is no razzle-dazzle here. You have to listen to some amount of theory. Stop yawning. And use prophylactic antibiotics, cycloplegics. If the pressure is high, anti-glaucoma medication. Now, what is the surgical management? Debridement, which is important, which Sir said, amniotic membrane transplantation, tenonplasty, and what has now come in as alloslet. Now, amniotic membrane, how does this help? Sir has shown a lot of videos on amniotic membrane. Now, this is the most important. It is freely available now. Earlier, when I came out from fellowship 23 years ago, only it used to come from LVP. Now, there's local availability. You can use even non-preserved if you can clean it up properly. There is also gamma radiated, but they are not very effective. Dry versus wet amniotic membrane, you would prefer wet. And what you want the epithelial side up, the lower side, if you pinch it up, it's like vitreous. So you don't use that side up. It traps the inflammatory cells and induces apoptosis. So you can use it in acute, early reparative and late reparative phases. It has anti-angiogenic properties, antiseptic properties, promotion of epithelialization, also analgesic, can use it as a graft or as a patch. So AMG is our first tool, and here this was one case who had a thermal injury. So this was where the burnt epithelium was there. We used the amniotic membrane graft with fibrin glue, and he healed pretty okay. This was a guy with hydrogen peroxide, working in a chemical dye factory, fell in a puddle of hydrogen peroxide, luckily only one eye. You can see these air bubbles are there in the cornea and the conjunctiva. So this was a kind of peculiar thing, how the hydrogen peroxide caused this, caused the air bubbles to enter there. And he looked like this the next day, absolutely sloughed. So there was an amniotic membrane graft. This was done by Dr. Vanati. It stabilized temporarily, but later he didn't do so well. Now, there was a small video of amniotic membrane transplantation, nothing compared to SIRS. And this video, I think, the amniotic membrane is not sufficient. There is, you can find superiorly, there is more edema. This was not actually tuna here, but lot of thing. So did a the peritomy 360 degrees and put the amniotic membrane there. So I'm not showing much in detail. You can use, like Sir said, you can use 10-0 monofilament nylon, which we are using earlier. And then when you put on the conjunctiva, to make sure it's not gone, you can use 10-0 or 8-0 Vicryl. Now, tenon's advancement. When it is grade 4, 5, and 6, you have to remove all the necrotic tissue, followed by blunt dissection of the tenon's membrane, and advance the tenons. So this, what happens, it brings in blood vessels there. So this procedure was given by the Shankar Netralia group. And here you can find, this is the LVP group, which shows that inferior tenonplasty caused, despite amniotic membrane transplant, they found inferior limbal ischemia, which they could do, which they could help with the help of tenoplasty. And then they did further cornea transplant after that. So here they have shown the surgical steps of, here you can see absolute area of ischemia. You have peritomy, you're going down to the limbus, to the fornix, advancing the tenon's membrane, getting it in front. And like Sir said, when you have bleeding, you are far more better. Now in small perforations, you can use tissue adhesives and bandage contact lens, but you have to do an emergency patch graft or therapeutic PK in large perforations. What about alloslet, which Sir has mentioned? Alloslet in acute cases, you have to epithelialize the cornea. So alloslet, you get lot of, if you have a center which does cornea transplantation, central part is used for PK. Peripheral part, you can cut it into multiple bits and put. Here you do not need immunosuppression because this is just for acute case where you have to just epithelialize. So here you would not like to do slet from the other eye because the failure rates are very high in case of inflamed cases. So what is the modality of management? First stage, you have given chemical, you have given medical management, then you have put an amniotic membrane graft, then that didn't work, you may have to put it 2 to 3 times. In a government institution or in a bigger institution, very easy to convince the patient, acha, first surgery, second surgery, third surgery. But in the first case itself, you have to tell, if it's an industrial accident, then you have to tell the people who are going to pay for that poor patient that these multiple procedures will be required. There'll be tarsography required, there'll be amniotic membrane required, there'll be second amniotic, third amniotic, alloslet, and so many things, so on and so forth, and tenoplasty. And you have to, without giving much recovery to the patient. Same patients you will be following up for 2 years, 3 years. So alloslet is the second one. Intermediate phase. People have said that after 1 week, do not give steroids. No, you can give steroids if you have put amniotic membrane, that will help. The other thing is, if you have given a lot of ascorbic acid, all the textbooks say if there's enough level of ascorbic acid in the aqueous, steroids will not cause a melt. So just taper it a bit. You can also use dipomedrol or something like that, but to also look at surface reconstruction. So the proposed classification, sir has already showed conjunctival autograph, cadaveric autograph, living related, conjunctival limbal, and keratolimbal. Living related, it's not so easy. Only sir can persuade the living relatives to give. The rest of us do not have those persuasive powers, but then again, you can tell them if it's a bilateral case. So how do you do it? Unilaterally, grade 1 medical management, 2 and 3 medical plus minus AMG, 4, 5 and 6 medical initially, conjunctival limbal graft from the other eye, simple limbal epithelial transplantation, and cultivated limbal grafts. Bilateral are the most severe, difficult to do. Grade 1 medical, grade 2 and 3 medical plus minus AMG, 4, 5 and 6 tenoplasty, cultured limbal cells from the living relative, comet, that is cultured oral mucosal transplant, or as a last resort, keratoprosthesis. Now all of these has been done by sir and everybody, in LV Prasad or Shankar Netralaya. We have gone up to tenoplasty, I should say, and also SLET, but not done cultivated yet because it needs a lab and needs a lot of expenditure. Oral mucosal transplant, taking from the buccal mucosa and transplanting. Why people did not use it too much is because vascularization occurred because of buccal mucosa. And it's not the same phenotypically as the conjunctiva. Now, successful management, several papers have been done for limbal epithelial transplantation, and also for the keratoplasty after SLET. There are many papers there. So like sir showed, 2 to 2 mm of donor tissue placed on the amniotic membrane. Here you can see one of my colleagues has done just a localized SLET. Like there are many modifications. There is mini SLET, there is top-up SLET, there is SLET for pterygium. So many different, there is a sandwich technique. There's a first technique where you can put it directly on the cornea and put the buttons on the cornea, put the membrane on top, or put a membrane, put the buttons, put another membrane, sandwich technique. For pterygium, mini SLET or OSSN. So many utilizations of SLET has been. And you can take, suppose it is autologous, one area is less, and you can take it from the other area and put it in the same eye too. Now, PK after SLET, better to do in 2 stages rather than 1, and rather than a single stage procedure. Lot of complications can occur in chemical injuries, like a non-healing epithelial defect, corneal opacity, cataract, glaucoma, dry eye, lid malposition, symblepharon, trichiasis, and late rehabilitation. The causes of in diffuse stem cell deficiency, you can use keratolimbal allograft, conjunctival limbal autograft, cultured limbal stem cells, large diameter PK, and keratoprosthesis. Now the clinical presentation, sir, has already shown how the limbal stem cells, the conjunctival stippling, and how the conjunctivalization occurs, and you can see the difference between partial and total LSCD, and you should know the difference. Confocal microscopy, and in cases of limbal stem cell deficiency, you can see there is a loss of normal epithelial cells and severe vascularization and presence of inflammatory cells. When I just learned from sir and came back, that time there was no SLET and no alloslet. So I have done a keratolimbal allograft. This was way back 20 years ago. Did not know that he had to be immunosuppressed, and he actually failed. Or rather knew it, and the other colleagues were a little scared, and they did not allow me to give immunosuppression. So it was my fault, it failed. You can also take conjunctival limbal autograft from the other involved eye in case of unilateral, or from living relative in bilateral. Already sir has talked about cultured limbal stem cells and autologous oral mucosal cells, we have also said. Xenograft transplantation, endothelial cells cultivated on amniotic membrane have been successfully transplanted by Kinoshita, not yet available. Nasal mucosal grafts will contain goblet cells. This has been used by some people, but there's a lot of rigidity. Large diameter therapeutic PK, well, it can fail. It can give tectonic support in the initial stages. Keratoprosthesis, I have learned from sir, but not done enough because they are very expensive. $500 is the minimum that you spend, but the Oro Capro maybe for $50 itself. And in bilateral severe injuries with irreparable ocular surface damage, or 4 to 5 transplants have been rejected. So you have the Boston K-Pro, where you have the donor graft punched in the middle, the front part, the back plate, and the locking ring. And also modified osteoodontokeratoprosthesis, which takes several hours and several dedicated teams to take the canine tooth, to drill a hole in it, put the cylinder, put it in the cheek, allow tissue to grow in, then second stage, take it out, put it on the eye after a mucous membrane graft. Thank you.
So, hi everyone. That was a very interesting response from all of you, by the way. Like the WhatsApp is flooded, of course, and we still are receiving more messages. We'll take care of that. We request the chairs, sir, Varun sir, 1 second. So there's a little shift in the plan. So I just wanted to tell you guys. Actually, unfortunately, we couldn't have Dr. Sharadini Vyas ma'am with us over here today. So Dr. Shreyas Ramamurthy sir has been very kind to take over the topic because it's an important topic for the postgrads. So we're covering that for you. As he has to leave early, he's taking it earlier for you guys, okay? After that, it will be the lunch. So I request the chairs for the next session to please come over. So the next session is the Cornea 2 session, and I request Dr. Varun Malhotra sir and Dr. Rohit Bang to come over to the dais, and I request Dr. Shreyas Ramamurthy sir to please take over for the topic on corneal dystrophies and degenerations and interactive session.
Thank you so much, Rolika, and Madam's talk was exhaustive, wonderful, and of course, Sangwan sir had a masterclass before that. If Madam found that you all were yawning, I think I'll find you all snoring during this dystrophy talk. So corneal dystrophy, as it is even in the best of times, is a dry topic to discuss about. But I'll try to do my best to alleviate some of the boredom and try to keep it as salient and as important as possible with regards to the points. And one important thing with dystrophies is pattern recognition. Really looking at different pictures of the dystrophies is what is ultimately going to enable you to diagnose these conditions. So let's quickly go over some of them. So what essentially is a dystrophy? It's basically it's derived from a Greek word which means wrong nourishment or difficulty in nourishment. So essentially these are all inherited corneal diseases. They're usually bilateral, usually symmetric, slowly progressive, starts from the early part of life and is progressive, and is generally not related to environmental or systemic factors. However, to every rule there is an exception. Bilaterality usually common, but then posterior polymorphous corneal dystrophy could be unilateral very often. Usually we don't have systemic and environmental factors, but in Schneider corneal dystrophy, hypercholesterolemia is a risk factor, which is a modifiable risk factor. Usually all these diseases are hereditary, but there are certain dystrophies where a hereditary bias has not been identified yet. And most of them are progressive, but Fuchs dystrophy in stage 1 can actually be non-progressive, and you can get away with a very safe cataract surgery in these patients without them progressing at all. So classically we had the anatomical classification, and that is how I will discuss the rest of the topic. Essentially we divide them into epithelial and subepithelial, then the Bowman membrane dystrophies along with the anterior stromal, the stromal dystrophies, and the Descemet's and endothelial dystrophies. But the IC 3D classification of corneal dystrophies, there is a certain difference which has been pointed out, and there are 4 categories, category 1, 2, 3 and 4, and it's important that you at least know what these categories are about. So basically category 1 is our standard dystrophies, where we know it's a well-defined dystrophy, the exact gene, the exact locus on the specific mutation has been identified, and these are the category 1 dystrophies. Your typical granular, lattice, macular, all of them come under category 1. Now there are certain dystrophies which are category 2, wherein it's a well-defined dystrophy, we know all the clinical features, but the specific chromosomal loci has not been identified, or the specific gene which is responsible for the mutation, we don't know. Then you have the third category, where we are fairly confident about the consistency in the clinical features, in the morphological features, but we have no idea about the genetic basis or the gene or the chromosome has not been identified yet. Category 4 are essentially the rare dystrophies, where only a handful of cases have been seen by even the most experienced of cornea surgeons, where it is difficult to pin them down into one category, and they are all put under the basket of C4. So coming back to the anatomical this thing, we will be talking about epithelial and subepithelial dystrophy. And in the epithelial and subepithelial, they are now, some of them are grouped under what we call TGF beta 1 dystrophies. So this is a particular gene mutation which is responsible for causing recurrent erosions, and all these which have the TGF beta 1 mutation are classified as the TGF beta 1 dystrophies. So let's go on to the most common and the first dystrophy, which is the epithelial basement membrane dystrophy. Now the epithelial basement membrane dystrophy is very, very common, but very often missed, because it has very subtle presentations, and only if a patient is symptomatic because of recurrent corneal erosions are they even diagnosed very often. So they can be present as either these micro dots, or you can have these whorls which can be present in the form of a fingerprint, or you can have a very geographic appearing look on the cornea, which is what we call maps. So either they have a fingerprints or dots or maps, and these are essentially what you see here is essentially what we would call a more geographic looking appearance or a map shape of the dystrophy. Now the reason recurrent corneal erosions happen in this dystrophy is because there is a reduplication in the basement membrane. So as you can see here, as the basement membrane goes into the layers of the epithelium, the layers of the epithelium which are anterior to this interdigitation are not receiving the nourishment from the below layers. Their attachment, the hemidesmosomal connections are poorer. So they tend to slough off. Because of these patients get recurrent corneal erosions. So you can also identify them with the negative staining, as was shown in an earlier presentation as well, where you are able to make out these lines and whorl patterns a little better. Now very often they are asymptomatic, and they may have some amount of irregular astigmatism caused by the patterns, but most often they will present to you only because of a recurrent corneal erosion. The typical history that you would get is on awakening that they had a severe pain and irritation, and very often it gets better over the course of the day, and if they are presenting to you later in the afternoon, you may not even make out an epithelial defect. Along the edges of the defect, you see these kind of micro dots. These are what are classical of a patient having had a recent onset recurrent corneal erosion. Now the treatment initially is conservative, where you can use basically a bandage contact lens, use lubricants, plus or minus hyperosmotic agents, and they generally resolve. But when the patient continues to have recurrent episodes, then some form of treatment is necessary. In the older days, stromal punctures were being attempted, especially if they were not in the central visual axis, so to cause a localized scarring and prevent erosions. This can be useful, especially if it is a post-trauma, you have a localized erosion. But in epithelial base membrane dystrophy, where it is diffuse and where it can happen in bilaterally and anywhere in the cornea, you would have to either do a alcohol epithelectomy and then allow it to grow back, or most often what we do is a PTK. So essentially what we are doing with the PTK is we are removing all the faulty epithelium, all the interdigitations which you saw in that biopsy picture is all removed, and then you also ablate the portion of the base membrane and the Bowman's membrane. So now when the epithelium grows over the surface, it adheres well to the anterior stroma, and because of this there is a reduction in the recurrent corneal erosions. Again, patients who are to undergo a refractive surgery, this is very, very important, as if you miss an EBMD, post LASIK they can have recurrent corneal erosions, and that's something very important. Morphologically, we have microform and macroform erosions. Microform are the ones which are usually because of a dystrophy and can be bilateral, small, and they resolve very quickly. Macroform are the ones which are larger. These are usually caused because of trauma, and they usually unilateral because of trauma. And they are, of course, the incidence may be less frequent, but they are more painful, take a longer time to resolve. I'll quickly take you all through a couple of other superficial epithelial dystrophies. One which is the Meesmann dystrophy, where you see these kind of microcysts. So, couple of points we'll try to remember with each dystrophy. One, what is the pattern of inheritance. Majority of them are autosomal dominant. When it is a little different, I'll try to highlight it. You can see these better on retroillumination, as you can see in this picture. But one very classical point about Meesmann dystrophy is that the uninvolved area, the intervening epithelium is completely clear. So you'll have these microdots, diffuse microdots, intervening area which is clear, and then again some microdots in the inferior. On light microscopy or confocal microscopy, you have these vacuolated appearances, and this has been described as a peculiar substance, the deposits that you see on the dystrophy. Next is a leash dystrophy. The leash dystrophy has a slightly different inheritance pattern, which is X-linked, and it has this typical feathery whorled band-shaped appearance. So you can see it's a typical feathery appearance, again better visible on retroillumination in a dilated state. So again on light microscopy, you have these large diffuse vacuolated appearance with the deposits. One very typical feature which has been described on confocal is again there is a reversal in the way a confocal picture is. Normally you have a hyperreflective nucleus and a hyporeflective cytoplasm, and this is reversed in leash dystrophy, and this is a typical feature. Again, a significant demarcation between involved and uninvolved areas. The involved areas have a completely different appearance, the uninvolved areas have a completely normal looking confocal features, and there is a perfect demarcation line. So just a couple of points which you can remember about the dystrophy. Now one not so common but very, very visually significant and important superficial dystrophy is the gelatinous drop-like dystrophy. Now this is an autosomal recessive condition. Most of them are autosomal dominant. This is autosomal recessive, leash is X-linked. This is characterized by the deposition of corneal amyloid in the subepithelial surface. Now because of this, they are usually present very early in life, first decade of life, they rapidly progress, and by the third decade the vision is severely impaired, and you can see this picture from the first to the third decade. They have, based on their appearance, now normally we say in dystrophies the cornea is completely avascular, which is not the case in gelatinous drop-like dystrophy or GDLK, where you can have vascularization and you can have this band keratopathy kind of appearance. You can have the kind of opacification also which is associated with it because of recurrent depositions. You can have this is a condition which is very, very common in Japan. So they have a particular fruit called kumquat, and they believe that this looks like a kumquat, but basically it's a diffuse involvement, or you can have a mulberry involvement, this kind of droplets of the gelatinous surface. So GDLK is important to remember because of its 100% capacity to recur. Whatever you treat, all dystrophies have a chance of recurrence, but the recurrence is usually slow, takes several decades, and therefore it's not a condition, it's not a problem that you need to be very, very worried about. But with GDLK, you will know that you are going to do recurrent procedures for these patients. So initially we start off with superficial keratectomy, just do an amniotic membrane graft. When things get worse, when there is more opacification, you do lamellar grafts. When things get worse, you do a PK, and maybe if it's a bilateral severe involvement, multiple failed grafts, multiple recurrences of GDLK, even a K-Pro could be considered. So essentially, thing to remember is recurrence, and you will have to do multiple procedures for these patients. Now comes the group of dystrophies called the TGF-beta1, like I alluded to earlier. All these dystrophies are characterized by recurrent corneal erosions. The reason is because this TGF-beta1 codes for a protein called keratoepithelin, which is necessary for cell adhesion and migration, and when that is faulty, there is a higher incidence of recurrent corneal erosions. So the first of them is the Rees buckler. Now Rees buckler and Thiel-Behnke typically involve the Bowman's and the sub-Bowman's area. So they have this in Rees buckler, you have a typical grayish white reticular opacification involving the Bowman and anterior stroma. Again, it is thick in the center and reduces as we go into the periphery. In Thiel-Behnke, you have this typical honeycomb pattern as we call it, and basically the Bowman's layer or the basement membrane is replaced by a fibrofatty tissue, and this can be seen as an undulating pattern, and you can see it on ASOCT as well. This is just an example of a patient which I saw a couple of months ago, who presented with this kind of very irregular anterior surface, vision of 624. Again on ASOCT, as you can see here, a typical undulating appearance because the the basement membrane has been replaced by a fibrofatty tissue. It's important for intervention and for subsequent treatment that we measure the depth of this. So you can either do a PTK laser on the surface, or you can do an anterior lamellar keratoplasty. Because most of the deposition was in the first anterior 100-120 microns, I did a PTK, and this is how the cornea looked in the post-operative period, from a fairly very irregular anterior surface to a clear surface, and the ASOCT also became completely clear. This is just showing different sections. There will be a few residual opacities in different regions, but by and large the cornea is optically clear and the patient does quite well. Moving on to the typical stromal dystrophies, the granular and the lattice. Now granular and lattice still belong to TGF-beta 1. The macular does not belong in it. So macular dystrophy does not have recurrent corneal erosions, whereas granular and lattice patients can present with recurrent corneal erosions. In granular also we have different types. You have the superficial variety or the breadcrumb variety, where essentially in granular you have these breadcrumb opacities where the intervening space is clear. This is important to remember because in macular the intervening spaces will be hazy. In granular the intervening spaces will be clear. So you have the early type and the later type. The type 1, which is usually a superficial involvement, recurrent corneal erosion is very, very common, and the mainstay of treatment is PTK. In the type 2, the deposits are deeper, they are larger in size, and here because they are deeper, they don't cause as many recurrent corneal erosions, and the treatment is usually a lamellar keratoplasty, either an ALK or a DALK. At least in these three dystrophies, I think it's a common or a favorite exam question to ask what is the material and what is the stain used for it. And in granular dystrophy, essentially you have hyaline material and it stains bright red with Mason's trichome. So try to remember some of these pictures, and I'm sure all of you will be aware of the mnemonic as well. The PTK treatment for granular dystrophy is again very, very useful in the superficial variety, and once these opacities disappear, the patient has extremely good vision. Again, the aim of PTK is not to remove every last opacity. It is essentially to reduce the amount of opacification which is in the superficial layers, reduce the amount of light scattering caused by these opacities, and there is a significant improvement in visual quality in these patients. You may have a few scattered opacities here and there, but the patient does quite well. Again, anterior lamellar keratoplasty, you could do a manual or a microkeratome assisted or a femtosecond laser assisted. Femtosecond laser assisted is useful especially when you have intervening clear spaces like in granular. If you have a diffuse opacification like in macular, even if it is a superficial involvement, which is not common in macular, but it will not penetrate through. So you need clear intervening spaces for the laser to penetrate through. And if it is within the first 200-250 microns, you could even get away with a sutureless keratoplasty. This is just one example of a combination with a patient with GDLK, where after peeling the anterior surface and a keratectomy, the underlying scarring, you could do a partial trepanation. This is a manual ALK, and the reason I'm showing all these procedures is because there are options and there's no one tailor-made approach to all these patients. And like I said, in GDLK, you may have to do repeated procedures. So you start off with a superficial keratectomy, later a manual ALK, then a DALK, then a PK. Lattice corneal dystrophies, again, you have these refractive lattice lines, these refractile deposits, and the peripheral cornea is usually less involved. It's mostly the central cornea. recurrent corneal erosion is most common among the TGF-beta1 dystrophies. It's most common in lattice corneal dystrophy. And this is also characterized by corneal amyloid deposits. In GDLK, the amyloid deposition is different in morphologically compared to lattice, but when you look at it pathologically, this also contains corneal amyloid. Based on the location and presentation of age, it is classified into 4 types. Suffice to remember that in the early type, the presentation is early, involvement is more superficial. As you go into the later stages, the presentation is in the later part of life and the opacities become larger and deeper as compared to the early stages. So at least that much if you can remember, you can just classify them into type 1, 2, 3, 4. One additional point would be type 2 is associated with systemic amyloidosis. So again, most of the dystrophies do not have any systemic or environmental factors, but in type 2 lattice corneal dystrophy, you can have systemic amyloidosis as well. Lattice corneal dystrophy has amyloid deposits which stains again this red color on Congo red staining, and it also shows the birefringence on polarizing microscopes. Now going on to the typical stromal dystrophies, the macular dystrophy is while the least common of the 3 classical, granular and lattice, but it is the one with the earliest presentation. And because the vision becomes defective faster, these are the patients which present to our clinics more often than even the granular and lattice patients. So this is again, most are autosomal dominant. This is yet another which is autosomal recessive. This has diffuse corneal clouding. This has that is the intervening spaces are not clear. The involvement goes up to the periphery and goes to the posterior cornea as well. Most of the dystrophies will involve the central cornea. Periphery is relatively spared, whereas in macular dystrophy, the involvement goes on to the periphery. Usually again, most of the macular dystrophies start in the center. As the patient ages, it goes to the periphery. The involvement starts more anteriorly and goes more posteriorly and to the periphery as the patient ages. Again, macular dystrophy has mucopolysaccharide deposits with Alcian blue as the staining pattern. Again, 2 types. Though morphologically very difficult to differentiate, but in type 1, essentially in our glycosaminoglycans in the corneal stroma, we have keratin and dermatan sulfate. Now, in type 1 macular corneal dystrophy, the keratin sulfate is lacking, because of which the ground glass appearance from the dermatan sulfate deposition happens. In type 2, the ratio of keratin and dermatan is maintained, but the synthesis is reduced. So this is the difference between type 1 and type 2. And this fairly popular, I think, PG entrance exam mnemonic of Madeline Monroe always gets her men in LA City, gives you for macular dystrophy, mucopolysaccharide, Alcian blue, granular hyaline, Mason's trichome, and lattice amyloid Congo red. I think all of you can be happy that you don't have to remember these things for PG exams, but in case examiner is curious, it's worth remembering. Now, Schneider corneal dystrophy is again a very important dystrophy again because it causes a lot of visual discomfort, and it is more common than we believe it is, because very often it gets misdiagnosed as lipid keratopathy, but this has lipid deposition without any vascularization. So lipid keratopathy is actually a degeneration, it is not a dystrophy, and that is usually caused secondary to inflammation and the vessels coming in, whereas in Schneider dystrophy, we don't have any vessels there, but you have these fatty deposits. Initially starts off in the center, then you have a very diffuse involvement with this arcus lipoides as well, and there is a progression as we age, and it is a localized disorder of the lipid metabolism, and it can be associated with familial hyperlipidemia. Congenital stromal corneal dystrophy is a rare condition, but it is worth knowing because this can presents at birth, and it is an important differential diagnosis for SHED as well as congenital glaucoma. And unlike SHED, where you could do an endothelial keratoplasty, here you would have to do a penetrating keratoplasty or a DALK to improve the vision, and that's one of the reasons why this is important. Fleck dystrophy, again more for academic interest. It's usually asymmetric, very unilateral, and you have these fleck-like, dandruff-like deposits in the cornea, and is usually an incidental finding, and the patients don't have any complaints whatsoever. Predysmetic dystrophy, the reason I've highlighted this is very often you'll have very poor specular counts in these patients because the specular is not able to capture the endothelium, and these patients may get referred to you as Fuchs dystrophy. But these patients are non-progressive, and they just have, if you make a slit in the cornea, you'll find a diffuse reticular opacification in the posterior stroma, just anterior to the endothelial decimase complex. And these patients don't progress, and they don't have any visual deficits. You just go ahead with a plain cataract surgery for these patients and they'll do extremely well. And that is the reason why you need to know that such a condition exists, because you don't advise an unnecessary DMEC or DSEC in these patients. Quickly, last 2 minutes of the endothelial dystrophies, where the most common, which is the Fuchs endothelial dystrophy, and this is, I'm sure, something which all of you are familiar with, and they are characterized by these typical corneal guttae. There is a decrease in the sodium-potassium ATPase pump function, and that as a result of which there is corneal clouding, swelling of the cornea, and usually these are patients with present in the cataract age group in the 4th and 5th decade onwards, and therefore it becomes important in co-managing the cataract with the endothelial dystrophy. Usually in stage 1, you have guttae, you have decreased counts, but many of them do not progress. So you could go ahead with a safe cataract surgery using viscoadaptive agents, and they do very well. But in stage 2 onwards, that is stage 2 where you have frank endothelial decompensation, patients have these early morning symptoms where there's more clouding in the morning. These are patients where you would have to combine the procedure with a DMEC or a DSEC. Stage 3 is the more advanced one where they have bullae and rupture of bullae leading to superficial scarring, and if there is a lot of scarring, then maybe there would be a little bit of compromised vision after endothelial keratoplasty in these patients because of the scarring. This is a relatively old suggestions given by AAO guidelines, where they said a pachymetry of greater than 640 or specular less than 1000 or early epithelial bedowing, early morning symptoms. These are patients who could be combined with a DSEC or a DMEC rather than doing a cataract surgery alone. But however, in clinical practice, we all see that patients even with extremely low counts do extremely well with just cataract surgery alone and don't often decompensate. It's very, very rare that they decompensate when the cornea is compact. So most often in an Indian setting, in a compact cornea without any decompensation, we don't do these combined procedures. But if there is early decompensation, they do extremely well with a combined procedure. Posterior polymorphous corneal dystrophy contains these either bands or discrete opacities and vesicles. It's important to know because this is a dystrophy which you need to differentiate from Fuchs dystrophy. Now, posterior polymorphous corneal dystrophy is also fairly common. I mean, you will see it more regularly than most of the other dystrophies that we spoke about. And the reason this is important is, again, when you are performing cataract surgery for these patients, you need to be a little bit more careful. A specific feature of the posterior polymorphous corneal dystrophy is that the endothelium behaves like an epithelium. The epithelium becomes multilayered, it has microvilli, it stains positive for cytokeratin, some of the cytokeratins like CK7, CK8, 18 and 19, and this is a typical feature of posterior polymorphous dystrophy, and it also has desmosomal intercellular desmosomes and has a proliferative capacity. Basically, all the features which you think of for an epithelium is there for an endothelium in posterior polymorphous dystrophy. The last one is the shed or the congenital hereditary endothelial dystrophy. Now, this has diffuse bilateral corneal clouding, but the severity can be, or what we thought earlier could be, variable in terms of its presentation. Again, usually presents at very, very early stage and needs to be differentiated from congenital glaucoma. Earlier, we used to have something called shed 1 and shed 2. Where shed 1 we said autosomal dominant, slowly progressive, less severe. Where shed 2 is the autosomal recessive one, severe corneal clouding, early presentation, and could even be associated with nystagmus and hearing, sensorineural hearing deficits. But of late, shed 2 is what is being christened as shed, and shed 1 is possibly no longer an entity and is just a variant of the posterior polymorphous dystrophy itself. So the reason is that the endothelial cell count is reduced significantly, and therefore there's diffuse clouding, and there is a significant thickening in the endothelial complex itself. Yeah. So any doubts? And if not, I think we should close here. Thank you. Thank you so much for your attention.
Thank you so much, sir, and a special thank you to you for being ready to cover the topic for the postgrads within 24 hours. So that's very kind of you, sir. And now comes the time that you guys are waiting for before we shift out for lunch. So the quiz that ma'am had very interestingly put up, I'll just tell you the answers for the quiz so that you guys know whether you were right or wrong. So the answers were CB, CC, CD. Okay, does that help? CB, CC, CD. All right. Now you can try to recall what were the questions. However, nobody wants to know the winner, is it? Oh, these are the ones who did not submit, maybe. Okay, fine. So, so let's. I request Dr. Vinitha Sangwan sir to please come on the stage, as ma'am has requested that she would like you to give away the book prize to the winner. And ma'am, please, we request you also to come upstairs. So the interesting part is that we got multiple correct answers. We were not expecting so many. So we had to, kind of go with the fastest finger first. And that way, the first person to win is Jyoti. 115 is the number. So is Jyoti around? If Jyoti is not around, it goes somewhere else. Right. Okay. So Jyoti, you can come over. And one of her friends can, spot for a 30-second reel for her going on Insta. No? Nobody? Yeah? Come over then. Fine. You can come up front. Doesn't matter. Come up.
क्या देना है कहाँ है अच्छा ओके 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 कोर्निया वाली कम
So this is ma'am's book, Cornea Illustrated. And it goes to Dr. Jyoti. Dr. Jyoti, you would like to introduce yourself? Please go ahead.
I am PG. I have passed my PG graduation this year from AIMS Rishikesh.
Congratulations. So unfortunately, we had to break in between. We apologize the chairs. So we'll proceed for lunch, and we will meet sharp at 2:30. No delays. We are going perfectly on time. Okay?